And I'm so excited to really introduce to you two speakers and learn from them about exploring possibilities for better health care. For the first speaker, Dr. Rose Constantino. Dr. Rose Constantino is an associate professor at the University of Pittsburgh School of Nursing, Department of Health and Community System, and she teaches forensic nursing. She is the senior editor of Forensic Nursing, Evidence-Based Principles and Practice, published by F.A. Davis in 2013. Her pro bono family law practice is founded on her research on the consequences of intimate partner violence on health, safety, and well-being of women, men, and children worldwide. Her current research is in comparing the effectiveness of online and face-to-face intervention in women and children in intimate partner violence. She is mentoring students in developing the Help Zone app as training tool for bystanders worldwide in recognizing, responding, and preventing relationship violence, including domestic and sexual violence. Without further ado, I would like to present to you Dr. Rose Constantino, who will talk about exploring a global paradigm shift in health through CARE, strengthening the bond between global communities and health outcomes.
Okay, thank you very much. And I am so happy to be here with you this morning. It's an early part of the day, and I hope we'll learn something from all the speakers for the day and bring it home with us. Now, there is a slight change. I was supposed to be doing the research study that we did on our journey in finding the different ways of intervening with intimate partner violence, but now I thought maybe this is more fitting for today, exploring a global paradigm shift. I think there is a need for us to really look at how the world is getting smaller, because even today we're here from different parts of the world. We're brought together by this conference, and we're trying to really learn and improve health. So I thought I would bring this to you this morning. Hopefully we can take back home what GPS, what global paradigm shift is, and what CARE means. CARE is really collaboration, agility, resilience, and ethics and health. I think those are the most important consequences when you're changing you're shifting your methods of intervening with patients and treating illnesses. Discuss the core competencies in GPS and explain the meaning of CARE as it applies to GPS. So the purpose of this is really to share with you what our thoughts are in changing. It's not easy to change our paradigm. For example, we really should be looking at chronic illnesses now, because everything now will become chronic, and we have to live with them. Most people would have to live with them and function with chronic illnesses like diabetes, hypertension, CVD, cardiovascular diseases, Alzheimer's. We almost have to live with them, with those diseases. Describe the premises and values necessary in GPS and create a clear vision of our own GPS. I think that to start from us individually. GPS starts inside, and then we spread it as we teach, as we practice, and as we do research in our own unique niches in our practice. So our world is shrinking. It's getting smaller and smaller, propelled by the internet, all the wearable, mobile devices that we can now afford to get. And so if we look at the socio-demographics of people in the world and make them into like 100, reduce them into 100 people, I'd like to show this to you, what happens and what are the effects. I don't have to read. I don't want to read this with you. So I think that is a very good message. It's very telling that we are really in a different world now, and I don't know how we can unite each other to change our way of thinking and treating illnesses, and how we could have a better world. If we are the healthcare providers of everybody, 100 people in this world, I don't know if we could handle the changing needs of the population. So given that demographics, and if you are responsible for healthcare and responsible for the safety and security of those people, how can we provide with all those people in need? That's why we need, I think, to look at our global paradigm shift. It is really a smaller world than what you would imagine. We need to collaborate with each other. We have to accept everybody, and we have to be forced to lead. And it doesn't matter who you're leading, but you have to be a leader in this context. You have to be agile, flexible, and adaptable. Resilience means bending but not breaking. And then ethical in all our practice. We have to practice autonomy, respect each other, justice, be fair in all our dealings, and of course the truth, veracity, and faithful to each other. But this is like terms that we might just remember and recall or get hold of when we are tempted to do so many things all at one time. But think of care. It's collaboration, agility, resilience, and ethical practice. So paradigm shift, it is not easily done. It can be defined, but it is a change in the basic assumption or paradigm. The state of your assumption. How do we define illnesses before. Used to be somebody in bed, somebody who we have to care for the daily activities of the daily living, bathe the person, take them to shower, give them medication. But now it might be different. Now, as a caregiver, you really are the teacher of that person. You're not really the daily, the one that takes care of the person, but maybe be the leader, the supervisor, the encourager of that sick person. In Kuhn's idea of paradigm shift, he looked at it as a revolution, a worldview. So if you have start yourself, you have to start a revolution among ourselves in health. And think of your own way of starting a revolution, maybe in yourself, in your heart, or in your family. Your change of the worldview. And every rogue country has a nuclear program. Maybe that's for the world to see. But how do we encounter? How do we look at those things? Encountering unexplainable anomalies, disasters, fires. There's so much disasters now going on around the world. How can we be as one that we are united in those disasters, that people can cope? How can you teach them how to cope with those disasters that are so unpredictable, and it's almost like you can't understand what's going on, the shootings. How do you prepare those people? Can we really prepare, or are we just going to accept that that's what will happen? Encountering unacceptable happening. The refugee situation in Europe or here in the United States, are we going to accept that as it is as healthcare providers, or are we given a message that we have to look at how we can shift our paradigms, our ways of dealing with that? So it is then, the paradigm shift then is, I simplify this into a fundamental change in approach or assumptions that affects local, regional, national, and global methods of healthcare practice. An event that is unusual. It has to have a nudge in your heart that you want to change something. The usual and accepted ways of thinking, feeling, and behaving is no longer possible. It's no longer acceptable, and we have to change and to shift our strategies. So that is easier said than done. I'm spouting all these words for you, but I think if we think of it really solemnly in ourselves, we really have to force ourselves to do some kind of shifting. Characteristics of the global paradigm shift is making a shift from treating the disease. Instead of treating the disease, elevate the health of somebody to the point where the disease can no longer exist. Okay, so think again of the diseases that we have now, the chronic illnesses. How do we elevate a body of a person, or our own body, if we start with ourselves, so that the disease can no longer exist? You eat healthy, you stop smoking, you do exercise, you do things, and it's kind of that's a start for us. So in GPS, you have to have clear communication, a clean environment. Those are the requirements. Proper nutrition and exercise. I think we start among ourselves. So share with us your own personalized definition of health, because I have done mine. I thought that health in GPS is a GPS-informed community is being well, agile, and resilient physically, emotionally, spiritually, behaviorally, socially, and I included economically. Don't you think so, that in health you have to include economics? We really have to be healthy. There is no way that we can really remain healthy and participating in all the activities, if we don't have something that we can call our own, that we are economically able to do those things. And coming here is a sacrifice, I know, but we selected to come here to share with us, to learn from everybody, and also to see other people and learning how they practice in their own little niches in their clinical areas. It's not only the absence of disease, but even in the presence of disease and disasters. You think you can do that? You think we can do that? Thinking that we can cope with disasters and even in the presence of illnesses. So that's my definition of health. So think of your definition of health, how you can do that. Spiritually, it doesn't have to be religion, but spiritually is really our worldview, how we treat each other, how we define ourselves with higher being that would lead us in anything that we do. So that's what I mean by spiritually, but economically it should be included there. The building blocks of GPS is predictive. It's nice. If you practice GPS, it's that there's a predictive way of doing things. It can predict. You are now prepared to do what life will bring to you. It is preemptive, preventing or delaying diseases and disasters. So how do you delay an illness that your genetics has prepared you to have anyway? So delay the presence of that illness. Personalized, it has to be individually tailored, precise individualized nursing care, and that's really assessment, planning, implementation, and evaluation, APIE, that I think we all know with our closed eyes, knowing what we have to do in the nursing process. And that can be also applied in our practice. And it's participatory. Patients and families play an active role in decision-making and role-playing in participating. So the World Health Organization has listed a GPS competency, and it listed 11, I think. So, but communication is very important. It has to be credible and effective. So what do we mean by credible? It has to be based on what? It has to be evidence-based, okay, for communication to really be credible and effective. Knowing and managing self, that you yourself is an example of health. We don't have to be all tall and sexy and skinny and all that. Others are really given that kind of characteristics, but not all of us are like that. So, but we have to manage ourselves so that we are healthy in some way or another. Producing results, that's another competency in GPS. We produce results. Moving forward in a dynamic environment, in a changing environment, you're not stuck in one place, you're not really rendered ineffective because of the change of environment. We adapt, we're agile. Fostering collaboration and teamwork, that's very important. It's working for a common goal. And if our goal is to really improve health, I think we have a lot to do, and I think we can do all this to collaborate as a team in improving the health care of the world. Respecting and promoting individuals, and ELSI really means ethical, legal, and sociocultural issues, that we have to respect the people around us, and we have to learn from them regardless of their background and the information that we have to be attentive to them. Setting an example as a role model for everyone to see. I said 11, there's 13. And you can just take this with you, and I haven't developed really each characteristic, each specific behavior that would come with this competency, because it's still being built. um, um, I think occupying ethical leadership, promoting innovation. I think these are all phrases that we can really follow and blend it with the overall GPS umbrella, the competencies in GPS, ensuring effective use of resources, building and promoting partnerships across organizations and beyond, a vision of a healthy, successful future, and those are the ones creating an empowering and motivating environment. So really, you as a leader in GPS should be creators of empowering and motivating environment. When you go back home where you are and working, you can look at these characteristics, and we can't always accomplish all of them all at the same time, but maybe we can do it one by one competency at a time, and instill into the people that we work with when we go back home. So that is my definition of a global paradigm shift. There's more that I can say about it. I don't know how much time I have. Okay. So my global paradigm shift is I was a staff nurse, now I'm a forensic nurse. So these are the things that I am doing now, the sexual abuse. I went to class for this. I had a training on SANE, sexual assault nurse examiner. And then we learned how the business of human trafficking is going on around the world and how we can counter that. Do you know that it's a big business? Even political bodies, even governments are promoting human trafficking because it's big business. It brings them dollars and lots of money. And then the intimate partner violence. So I've shifted to my practice of forensic nursing. Okay, I would like to end here and maybe ask you about your own definition of health, and also just be brave with me and say, how do you define health? You can, or you want me to go back to my old definition of health? How do you define health? Do you agree that we have to adapt to be agile in health? How do you see now? How do you see or any question? Do you have any questions? If you don't want to add anything? Yes. Yes, Irene.
I really enjoyed your perspective first. That was very interesting. Thank you. I like your definition of health because my brain thinks of it as health promotion, health prevention of disease, but in fact, for all the people that we encounter, there is something, and I'll leave it that vague. And what we are trying to do is give them the best they can do with their mental and physical processes at that point. So that's a real interesting perspective.
Yeah,
I
it's like just a starter.
Yes.
So that you can really grow it in your own group,
Right.
in your own family, in your
Right.
own working
Right.
group.
I think with children,
Yeah.
we have to be role models for primary or universal prevention and do our best. But even with children, we're
Yeah.
seeing issues.
Yeah,
major
I don't
issues
think of the
today.
young children.
I've never seen so many diagnoses of ADHD.
Yeah, okay, any more comments? Yes, sir.
Thank you very much for your perspective of health. It is really inspiring. I'm just going to pick few points from your presentation that really touched me. The concept of people in need versus wealth is quite an important point that I took from your slideshow. It's very easy for us to say people in need as if, but if you look at the report from IMF recently, it states that 10% of the wealthiest people in the world own more than 70% of the world's wealth. So imagine if that 10% of the wealthiest people in the world would distribute that wealth to the needy people. then will we still have a needy? That's one thing. And imagine the disaster that devastated Haiti a few years ago. Imagine that was happening in the United States. Would we still have the same effect? And why is it that disasters, the wars, are so prevalent in the countries that are facing the most adverse social situations? What is it? What is going? And we need to think about our own position within this world that is devastated by wars, by disasters. And I'd also like your concept of care, your definition of care, because it really is something that as nurses we need to think about our own position and what is it that you are doing in this dynamic world. What is our influence in this dynamic world? Are we still looking at health in terms of disease, or are we looking in health in terms of the other things that determine those diseases?
That's really, yeah, those are very good thoughts and comments that you have given us. And I think hopefully we're all united here in this one room, that we really have to look at how we can individually shift our paradigm, our way of thinking. But you thought that really the Haiti disaster was a big one. Think of Katrina. It was just like Haiti, it was just like Japan, it was like everybody. I cried because the people in Katrina were just like anybody in the world who had this huge disaster. There's nothing we can do, and they were just as needy, as helpless as everybody who went through that disaster. So it's not United States, it's like the world. So when disasters come, it's really, we should look at it as a world disaster. It's not just Katrina, it's just not Haiti, it's not just the Philippines, Haiyan, and all that. So thank you very much. Thank you very much. Thank you. Hope to get that later.
Thank you, Dr. Constantino.
Good morning. Joe, I may need your help with this. Oh, I see it. I got it. Sorry. Thank you so much for being here this morning, early in the morning, as we resume our second day of the conference. And I want to talk to you today about strategies for women who are returning to work after a lapse due to depression. And one of the first strategies is the title of this paper, Removing the Mask, Women Returning to Work After Depression. Now, this is very much a work in progress for me. It's not quite complete yet, and actually last evening in my room I was working on some of this and had kind of an aha moment. So I feel like I can build on that in my work as it resumes when I return back home. Now, I do have some handouts if people are interested at the end that talks about the different strategies that are used. I'll put them right there. I'm from Canada, as you were told in the introduction. I'm from the province of New Brunswick, which is this little red province on the far east of Canada. As you know, it's a large country, and I live in the eastern part on the Atlantic Ocean. I teach at the University of New Brunswick, and it's one of the oldest universities in Canada. And it's a lot of red brick buildings that are nestled into the side of a hill. And it's really quite a beautiful campus. So getting down to this work on depression, the literature on depression has some compelling ideas. First of all, how urgent and complex this issue actually is. It's the leading cause of disease worldwide. And in Canada, with 1 million people suffering from depression, 70% of those people are actually in the workforce. Productivity, however, plummets. There's more lost work days than any other medical condition, and it's 5 to 10 times more common than other diseases. And as you know, with depression, the length of the episode is longer than what length of episodes for other chronic illnesses and illnesses are. People can be off work for 3, 4, 5 years with depression. It affects more women than men at a ratio of 2 to 1, and we question whether that may be related to the multiple roles that women play. So the purpose of this study, which is a grounded theory study, is to expand our gender-based knowledge. I want to inform policy and practice by exploring the experience that women have as they return to work after this lapse due to depression. So in terms of the methodology, it was a qualitative approach to research, grounded theory, as I mentioned previously. And I interviewed 40 women who had returned to work after a lapse due to depression. I used an interview guide. However, the interview was very conversational in nature. And I did a pilot project with 10 individuals. And that helped me plan and develop my interview guide. Now, it was a convenience and purposeful sampling technique. What I did is I posted posters around in different venues where I felt that women might have a look. I also advertised in local newspapers. And I did conduct this study in the entire province of New Brunswick, but it was an English-speaking research project because the province that I live in is bilingual, so it was an English focus. I wanted a community sample rather than a single workplace, and as a result, it included women from universities, hospitals, government offices, retail businesses, teachers, so they came from all walks of life. In the end, there were 40 English-speaking women over the age of 19 who had returned to work following depression. The age range was 23 to 64, with the mean age being 46.5. 19 of the women were single and 21 were married. 1 was First Nations or Aboriginal, and 5 were Francophone, but they were able to communicate in English. 10 were mothers. They were currently employed full-time, part-time, or seasonally, and they had had at least a 3-month lapse due to this depression. So you can see that many of the women in the study had multiple roles. data collection and analysis. Everything was audio recorded and transcribed verbatim. And I used a data analysis platform, NVivo, which I think you talked about using in your study as well. I did line-by-line open and axial coding, constant comparison, and developed categories. Then I went back to the women, and I went back to other sources like the literature for theoretical sampling. And from there, I started working on theory development. So what about this experience of depression? In the study, when I interviewed the women, they always started by talking about their experience, what it was like to have this depression. And inevitably, they described it as like being in a black hole. And I know I had read that in the literature, but almost every woman that I interviewed reiterated that it was this black hole. They had overwhelming fatigue and sadness. They had poor memory and an inability to concentrate. They had changes in their eating and personal grooming, and they were disinterested in activities of normal living. So as you can imagine, if these women are in the workforce, how difficult it must be for them to carry on as normal when they're so symptomatic. So depression and work, and these are a number of quotations from the women themselves. I couldn't get out of bed. I lived on the couch. They talked about just sleeping all the time or laying quietly on their couches. I got really behind at work. I couldn't keep up with the email. And I remember one woman in particular talking about how she was in a busy office and she was just so immobilized because of the number of emails she was getting, and she couldn't keep on top of them. They avoided social contact, and they had to put on a face. And this was something, and the picture with the mask depicts this. All of the women talked about putting on a face or wearing a mask. They did not want their coworkers, their employers, to see the real them. So they covered it up. If you wanted them to be happy, they would appear happy. They responded to the people around them, and they really covered up their true feelings. They were overwhelmed by the amount of work. They couldn't focus, and they had no attention span. So being at work was extremely difficult. Now, in terms of going back to work, they or being off work, they were relieved that they didn't have to go out of their house, that they could stay at home. Again, they talked about, I don't have to put on a face, or I don't have to wear a mask. No more acting. But they were worried about what people would think, and they found there was no contact from work. For most of these women, when they were off, they rarely heard from their coworkers. Whereas if it was somebody that had an MI or was in a motor vehicle accident or broke a bone, they might have a call from colleagues to see, how are you doing? But in this case, there was just silence. When they returned to work, they found they needed a gradual return to work, and that's certainly one of the strategies that I'm suggesting, is this slow return to work, and mainly because they have poor memory and little concentration. Returning to work, they found they didn't have any support, and here again it says if I had a broken leg, I would have that support, but in this case, I don't. And once they're back to work, the work is really piled on. It may be a gradual return in terms of hours, but once they're there, people consider them well and give them the regular workload that they would have. The alternative to that, some women talked about how when they got back to work, they weren't given anything to do. They just sat idly at a desk. So they either had work piled on or they didn't have anything to do. And neither one of those left them feeling very good about themselves when, at a time when they were already having a lot of feelings of worthlessness. This is what one woman had to say. I'm at the end of a hallway and I don't see anyone. I only see them if they go to the photocopier. I have nothing to do and no one to talk to. It is very strange. And what many of the women talked about is when they went back to work, they were moved to a different department, or it was as if they became an extra body and they were just being accommodated, but not necessarily back into the work that they were used to doing. So there were barriers to returning to work, and the number one being stigma and discrimination. And actually, when I said to you early on that I had an aha moment with my study last night, I really think the overarching theory that's within this study is living within stigma, and that overcasts everything else that the study says. Barriers to returning to work, the women were fearful of self-disclosing, and they were also worried about their lack of concentration. In terms of stigma, this woman said, because once you're tagged with mental illness, you're a problem to the corporation. You're either going to be laid off or fired, or you're just seen as somebody that cannot handle responsibility, that's too fragile. I cannot tell you the amount of prejudice in the workplace. Another person, one person that I told that I was off for anxiety and depression said, oh yeah, we're all stressed here, but we don't get to take the summer off. So really non-supportive. And you know, interestingly enough, some of these people I interviewed were nurses, and this is how they were treated by other nurses. There were also benefits to returning to work. There were barriers, but there were also benefits. And one of those benefits was economical benefits, because the women generally had been off for a long period of time. Their benefits had either all been used, or they didn't have any in the first place. Anyway, going back to work gave them that paycheck again, so there was that benefit. Also, the structure of the workplace was helpful in their recovery, and they were very socially isolated when they were off work. So this combated, or they felt it might combat that social isolation. Now, one of the recurring themes is that of battling adversity. And the women felt that they were in a constant battle of sorts. They battled the depression that just didn't seem to want to go away. They were up and down for a long period of time. But they also felt they battled the workplace. And that's where they were either put in a position where they didn't have anything to do, or they had an excess amount of work to do, but they were in constant conflict within the workplace. They also battled the institution, and by that I'm talking about policies that relate to people returning to work after depression, and the lack of support for that. They also found that wherever they went, there was an institutional focus rather than an individual focus. That was true in the institution, so policies that applied. It was true in the workplace, and it was true in the healthcare system, where they weren't looked at as an individual, but as a group. In battling adversity, this woman said, I was told by the insurance company that I had to return to work or my benefits would be cut off. I wasn't ready, but I went back. After my 30-day progressive return, I met with Human Resources, and they told me that my corporate values differed from theirs and that they were laying me off. Then the security guard accompanied me back to my office, and I picked up my stuff. They gave me $25,000 to shut up. I was disgusted, but too weak to fight them. Pretty horrible. Some of these women had worked in their organizations for 20 plus years, and to be treated this way. And it wasn't uncommon that they would be accompanied by a security guard to go pick up their belongings and take from their workplace. So they were almost treated like a common criminal. Another theme was the active practice of silence, and that permeated the workplace and beyond. The women worked hard at concealing their depression. They only strategically disclosed, and there was secrecy within the workplace. So, as you can see, much of that is related to that overarching theme of stigma that I mentioned earlier. Concealing depression, this woman said, so I didn't tell them I had a depression, I just told them I had surgery. It's easier that way. And another woman, I didn't disclose. I had taken some time off, and so they knew I was taking off for sick reasons. Initially, it was just vacation days and stuff like that. And in all honesty, I wasn't getting any support. So they were using their vacation days, their holidays, for sick time, just to try to conceal this illness. Another woman talked about the secrecy within the workplace. Yeah, it's the silence. If I had arthritis, they would be saying, hey, you want to check out this book or that site. But with depression, it's so silent. People did not come and ask them how they were doing in their recovery. There was that shroud of silence around them. Another woman said, part of my depression was a feeling of loneliness, and so I'm still feeling lonely within my work environment. I've been back now for 3 weeks. Nobody has come down to my office to see how I'm doing. But you see, there's kind of a double-edged sword in all of this, because colleagues don't come and inquire how they're doing and in their recovery. But at the same time, the women were concealing their way of being or their situation. So that further contributed to the silence around depression. One woman that I interviewed drew this picture to depict women wearing masks. And if you look at it closely at the bottom, there's masks. And she wrote this poem to accompany it. And I'm going to read that to you. The multiple masks of depression. Nurse, nurse, you may not see me, but I am here. Nurse, if you want me to be happy, I'll put on a smile. If you think that I'm sad, I'll put on that face too. You see, I have many faces. I aim to please. Nurse, nurse, do you want to see the real me? Come sit with me. Hold my hand. Let me know that you care. Let me know that you want in. Nurse, I want to be seen. Questions or thoughts?
I'm not sure which one is which. I didn't want to corrupt anything. Thank you. Now I have a spot. Over there? Okay. Thank you. Hi, everybody. My name is Mary Boylston, and I am from Eastern University in St. David's, Pennsylvania. And if you don't know where that is, that's okay, because it's a tiny, tiny little town it's a tiny, tiny little college. And we are next to Villanova. You ever hear that? And we're a little bit east from University of Pittsburgh. So it's a pleasure to be here today. I'm honored to be in your presence, and it is with great pleasure that I bring to you my study, or our study, Rose couldn't be here today, on students' preconceived attitudes toward the vulnerable, the poor, the marginalized. And I think it fits, whoever put this program together, it fits after Dr. Constantino's discussion about being globally aware. True, my population and my research was done on the main line of Pennsylvania or Philadelphia, and if you know anything about that, that's probably one of the most affluent areas in the country. But we still have issues, we still have these problems, and it's kind of a call to an awareness of what is there, and who is invisible. You know, in many ways, as Dr. McDonald had mentioned, invisibility. You know, you're invisible when you're depressed. You feel invisible, you're invisible. But when you're poor, when you don't have I suppose the niceties that we have when we have full-time jobs and we have our health benefits, it certainly is a challenge. And the biggest challenge is overcoming the barriers right now that are in front of those who do not have adequate health insurance. So is it a problem? Yes, it's a problem. So let's start with who I spent the weekend with last week. Okay, it was me, the Pope, and 2 million other people. But I saw him as he went by. I saw his arm and Secret Service and everybody else covering him up. So he does inspire me. I love what he says. He's a Jesuit who lives what he says. And that's rare in our society. But Pope Francis says that poverty in the world is a scandal. In a world where there is so much wealth, so many resources to feed everyone, it's unfathomable that there are so many hungry children, that there are so many children without education, so many poor people. And that's just one of the many things he has said. I looked down the list of his quotes and I thought, which one do I choose? There's so many good ones. So this was one. The next one comes from Franklin Delano Roosevelt, and he says the test of our progress is not whether we add more to the abundance of those who have much, it is whether we provide enough for those who have too little. Oh, I don't know how this one made it in there, but my doctor told me to start slowing it down, but there are more old drunks than there are doctors, old doctors. So let's have another round. And that's Willie Nelson, and he snuck in there. That's another presentation for tomorrow, But anyway, we do have Obamacare, and depending on what side of the fence you're on, you know, I'm on the side of the people's, you know, but I see both sides. Everything is fine. Okay, but it's not, is it? No. It's not. If you look at this grid that I picked up through the Kaiser Family Foundation, Families USA, you can see the poverty guidelines in the United States. Take a look at 100%. A family of one who makes 11.77 a year, they're considered poverty. Okay? Now look at your average family. They usually say parent, 2 kids, 3, maybe 4, 20,000, 24,000. If they're making minimum wage, you don't hit this. Okay? So in fact, in some cases, you make too much for Medicaid and not enough for Obamacare, and then maybe you make too much for Obamacare but not enough for Medicaid. Anyway, the issue is that it's convoluted and it's very confusing. We just tell people to go online and to sign up, but oh, guess what? They don't have computers, they don't have the internet. So how do we do this? Okay? We need to have advocates. Who are our advocates? It's us. It's us. Can I give a donation? Sure. Can I go to a soup kitchen? Yes. Can I make food for the needy? Absolutely. Okay? Can I pray for them? You bet. But I am one person. And after seeing Dr. Constantino's presentation, I'm one person for billions of people. So what can I do as one person in a little town in Pennsylvania, in a little college next to Villanova? What can I do? And the answer came to me that I can teach others to care for the marginalized and the vulnerable. That's my platform. That's my role. I'm not a saint. I'm a sinner. I do all kinds of things that are not good, and I do some things that are right. But the reality is, my platform is being here and being in the classroom. And I'm here to share with you and share with my students that there are issues that they have to deal with. Okay? And so by me sharing it with my students, they share it with more, and then so on and so on and so on. And hopefully that makes a dent, a tiny dent, probably a ding. When your car gets a little ding, maybe a little ding in the problem. But let's get started, right? Let's be aware. So here are the poverty guidelines. Alrighty. So why is this important? 8.1 million families in the United States are poor. Now, I should have gone globally, but Dr. Constantino, we're building on her statistics, her demographics. Okay, 8.1 million. 16 million American children live in poverty. That's a lot. Double the number who are considered poor. And you have 44 million, 1 in 3, who are served by Medicaid and CHIP in 2012. 41 million are uninsured. Multiple reasons for being uninsured, from I'm just not going to buy it to I can't afford it. Okay. And 82% are between the ages of 16 and 64, and 16% are younger than 17. 75% are from working families. So it's not like they don't want to work, and it's not like they don't want to have this. It's they can't afford it, or their job doesn't offer it to them. I know of places where you can make minimum wage, but they'll stop you at 30 hours or 29 hours through the week so that they don't have to give you benefits. They're hourly workers. This is what happens. And non-elderly Hispanics are the greatest percentage of those without. And there are, of course, 10 million who are undocumented without insurance. And because of this, 45,000 people die each year, and die from preventable things. They have more chronic illnesses, they're using the ER, or if they go to the ER, they're not getting the care that they want, or if they get the care, then what they'll do is they'll discharge them and put them on a bus and say bye. They'll give them a bus ticket. Okay. So here's some more statistics that are startling. 55% of working adults who make twice the federal poverty level in Texas lack health insurance. That's one of our biggest states. Uninsured rate tops 40% in Alaska, Florida, Georgia, Louisiana, North and South Carolina, Virginia, and Wyoming. This again is startling. We have low-income working families, okay, that's working. They have a job, okay? 80% with a family worker, 60% family income below 200% of the poverty line. Okay, the results are in. and they don't have preventive care. Okay? They don't get the mammograms. They don't have the PSA tests. They don't have their blood pressure taken. Okay? They're not checked for glaucoma. They don't have toothbrushes, and they have oral disease. Okay? And premature deaths. So we have two Americas when it comes to healthcare, divided by geography and income. And this is, if you want more specific information about this, it's Healthcare in Two Americas, published in 2013. Okay. So the reasons for being uninsured is some people feel that there's no need. You know, I'm young, I'm vital, I lift weights, you know, I'd rather have that car, that snazzy car. They would much prefer to put their money toward that. Fine, that's their decision. They lost their job. Insurance is not affordable. I know what I pay. You know, I know what my university pays, and then what I pay into it. And it's quite a bit. Okay? And then there are other reasons that people will give because they do not have health insurance. Some of the characteristics, and I'm going to put my glasses on because I can't see anymore. Okay. Family work status, there's only one or more who are working. Family income, look at the percentages. And it's also broken down into race. You have white non-Hispanics at the greatest percentage of 46%, Hispanic at 32%, black at 14%. Total amount, 41.3 million uninsured. Are they coming to your hospitals and your clinics? Okay, so what are the problems? The problems are there is an increase in unemployment, a decrease in insurance benefits, a decrease in opportunities. I look at some of the students who are graduating now. I work at a university, and it's taking them anywhere from 6 months to a year to find a job, if they find it. I was told the other day while I was in South Carolina that a teacher will make $17,000 a year. A teacher is making $17,000 a year. The woman told me that her son graduated. He's a teacher. He can make more money as a bartender, and he has left the teaching profession, and he's bartendering because he's got to live. Okay, so these opportunities are limited. And if you have the opportunity, sometimes it just doesn't pay enough. There's an increase in homelessness. There's an increase in poverty. We know increase in undocumented individuals. And because of this insurance issue, increase in communicable diseases. I know sitting on an airplane for 5 hours yesterday next to a woman who was coughing and she was shivering for 5 hours makes me think these communicable diseases are definitely out there, and I'm probably going to have one in a couple of days. So with that said, I'll try to get through this before I pass out. Then we have decrease in personal options. And I mentioned, you know, and you all know the options that are out there. You may want to live in Alaska, but there's no, you don't have the, you know, the capability of working. And of course there's these barriers in healthcare or to healthcare. So who cares? We do. We're here. We're here. We're here. I'm here. We care. Okay? And all these pictures that you see of people up here are actual homeless individuals who said, please take my picture and use it in your presentation, use it in your research. And I said, thank you. So this woman was on a bus and she died. She's a former nurse. Or once a nurse, always a nurse. She had hard times and then was homeless and was on a bus going somewhere, and she died. She doesn't look that old, does she? Mm-mm. So it's time to decide whether or not nurses are part of the problem or the solution, and this is where our research came in. Okay? So we begin with students. Actually, we began with me because part of it is what can I do, and the answer that I came up with, and maybe there are others that you can share with me, is to be, you know, the pulpit, be the, you know, but I'm preaching to the choir right now. Okay? My choir is not at school. Of course, right now they're so happy because I'm here right now and they don't have class. So there's a lot of smiling faces in St. David's today. They want me to present more, in fact. They said, Professor Boylston, whenever you need to go, just go. I was like, okay, thanks, gang. Anyway, this is basically what my research was all about, but in bold, you see, by identifying students' preconceived negative attitudes toward vulnerable populations, faculty can create curriculum and immersion experiences, exposing the students to what's out there, to the truth, the issues that plague our society, that plague our children, who plague women and children, the vulnerable. And then possibly, just possibly, we can eliminate this barrier to health care. The reason why this became so important to Rose and myself is because we read a study where the research, I can't give it to you right now, the name of it, but the researchers looked at the way individuals who were working in clinics, in ERs, and primary care facilities for the poor would respond to somebody who looks overtly impoverished, mentally ill, or whatnot, and their faces would give away what they were thinking. When we talk about verbal and I got 5 more minutes? I got to hurry then. When we talk about verbal and nonverbal behavior, these preconceived notions, what happens is that they'll be standing there waiting in line, they'll look up, and the healthcare professional, the nurse, the doctor, whomever, will look at them with a look of maybe disgust, or that's what they could perceive as being a look of, oh. How would you feel if somebody looked at you when you were coming in to be taken care of and they went, oh, and not thinking more of it, it might have been just a guttural reaction. Maybe all along they really did want to help, but the problem is their preconceived notion that they're poor and it's their fault. Yes. 1 minute. I got 1 minute. Okay. Anyway, what we did was we sent the students to a clinic where it was all homeless people. We had them immerse themselves into the clinic. We had a pre and a post-conference, and then post-conference, along with a forum, we came up with, sorry about this, folks. I just want to give you the results. The fact that these students, A, they didn't experience homelessness. B, they felt that it was the homeless people's fault, okay? And this was before, okay? And C, they suggest that the public is responsible to help. So, with that, I can't give this to you because I have 30 seconds now, but their response is in a forum, and we had a focus group. They said they were shocked because there was a shelter in an affluent area. Sorry about that, okay? They didn't know what to expect, so that's our issue. We didn't prepare them well enough. And they said, oh, by the way, they look normal. Okay? Many individuals are one paycheck away from being homeless. Students do not fully understand the actual role of what a nurse is supposed to do. My fault. I got to take care of that. And they did not know how to approach the clients. They didn't know how to walk up to them and say, hey, how are you doing? Because they didn't have any common ground to work on. So they concurred that it's necessary that we do this, felt it was a positive experience. And as a result, with this pilot study, these few students determined that it's important to have something like this embedded in a BSN program, a BSN curriculum. And with that, I have to stop because I have 30 seconds. I'm done. So anyway, I'm sorry I couldn't give it to you all, but I went as fast as I could.
Good morning, everyone. It's wonderful to be here, and it's really a pleasure. Some of what I'll be talking about actually goes along with what Dr. Bolston was talking about with poverty. I'm actually a program director at Western Carolina University for the Nursing Mentoring Diversity Program, and that's what I'll be talking about. There's 3 different components to the program. Where is Western Carolina University? You just saw where North Carolina is a state along the eastern seaboard, and Cullowhee, I'm sure not many of you have ever heard of Cullowhee, is a very, very small community of 2,000 people, and it's a term from Native American term for river, and our university is located there. It's a beautiful area of the United States. It's in the Blue Ridge Mountains, and this is a picture of our university. When we are in session, we have 15,000 students, but again, during the summer months, it drops to 2,000. So this is a very beautiful place. It's also in the most rural area of North Carolina, and it's in a very poverty-stricken area of North Carolina. Our school has a variety of BSN programs and advanced Bachelor's of Science degree programs. We have a variety of master's degree programs, nurse practitioner programs, nurse administration, etc. And we also recently started a doctorate program for the region. For our BSN program, there are very rigorous requirements, and there's essentially, besides a very high GPA that's required, there's an accumulation of hours that the students have to have with sciences and mathematics, and they have to complete 3 of the 5 sciences before they apply for the program. Our school is a little different also, that the students have to take the SAT or the Scholastic Aptitude Test, and for those of you from other areas around the world, you might not have that, but you might have something similar. And our school also has the TEAS, which is the test for essential aptitude skills. What is happening in the United States with the nursing workforce diversity movement is truly phenomenal. Right now in the United States, 81% of the nurses that work in the United States are white. And beyond that, there are very minimal nurses that are African American, that are Asian, that are Hispanic, and only 1.4% of the nurses are Native American. Our federal government has decided that, and this has been the last 10 years, that we need to change that because our population in the United States is quickly transforming to a multicultural and a multinational country. The United States is changing so dramatically that the nursing division of the government has decided that they will fund projects to help change the nursing diversity. And so this is one of the programs that has been funded. In July of 2013, we were very, very honored to receive $1 million grant, and this was to start 3 nursing workforce diversity programs to help increase the number of diverse students that are underrepresented in nursing in our area. And so we've been very excited to have this program. The purpose of the program is essentially to promote the inclusion of diverse students into our School of Nursing. Prior to this program, in a class of 25 students, we might have 1 or 2 students. So the purpose of this program has been to use evidence-based practice techniques to increase the number of students that graduate. Where is Western North Carolina? As you can see with the arrows are showing the 4 western counties, and these truly are poverty-stricken. Manufacturing is no longer part of the environment. People are in the lowest poverty-stricken area in the state. We also have the largest Native American boundary or reservation in this area, and that's the Cherokee Reservation. So all 4 of these counties, as well as this Native American boundary, are part of our nursing workforce diversity program. So what are the 3 programs that we've had? One has been a nursing workforce diversity mentoring program, and that's for pre-nursing students as well as students in a ribbon program, which is a bridge program from the community college. The second program that we've had has been with high school students to promote a pipeline program to have diverse students be in the pipeline to come into our nursing program. And this is through what's called the Second Life Virtual Health and Science program, and I'll talk about that for briefly. And our third is a week-long summer program that high school students from rural and diverse backgrounds can come and learn about nursing. So our number one goal is to increase the number of underrepresented ethnic minorities and students from diverse rural backgrounds that are admitted or retained into pre-nursing or nursing. So how did this get started? In 2007, we traveled to Montana State University and learned about the government program that was started there with Native American, actually 11 Native American tribes in Montana. And what their program was based on was extensive mentoring, extensive tutoring, and extensive celebrations and receptions to create a sense of community. Our program was established in the fall of 2013, and we were really excited that our first group, we had 12 students from our region. And these students were from a variety of diverse backgrounds. Here you have Jennifer Walking Stick with her mother and grandmother that are from the Native American area around Cherokee. So our program is based on their program, and we've been excited to have increased number of students. How were students selected? Students were selected by writing a 2-page essay on life challenges that they've had so far that has inhibited them from being able to be successful not only in high school but also to enter college. These students have a wide range of socioeconomic issues, just like Dr. Bolston talked about. A great deal of poverty with these families. The family support often with these students is not strong because of these students being first-generation students, and those are students that are going to college for the first time out of their families. And the academic progress for these students often has been very low, with very little support in the high schools. What we did with our program is we created as a very strong mentoring program, and the students receive their own personal mentor. And if you'd like to think of it as a tutor, they essentially have their own mentor. We're just now starting year 3 of this program, and it has been highly successful because we've been able to have mentors that are with each of these students that help them week by week through their academic program. Here are some pictures. Each fall and in the spring, one of the formations that was with the Montana program that I talked to you about was having celebrations and receptions and building a sense of community for these students. We have a reception in the spring and the fall. Here's a picture of Dr. Judy Newbrander, our director of nursing, and she's with one of our students' camera. And on the right slide, for my right, it might be your left, Mike Kavakos, who is one of our mentors, with Josh Carter. So each of our students are given awards. They're given certificates at the receptions for being successful, as well as the mentors. So we have a family-style meal at these receptions, and it's a way to create a sense of bonding. Here we have students, one of our students on the left, Letitia. She has a 2-year-old daughter, so she's struggling with having to raise her daughter as well as being in school at Western. We have on the other side another young student with her parents who is from a Hispanic background. Here's a picture of our reception, and another student that's from a rural Appalachian background. So our program is based on having a personal mentor, guided tutoring. They have focused 2 to 3 study meetings with the mentor a month. And I did not mention that our mentors are all formally trained. One of the roles that I have is being the mentor developer, and I've had to use a program to help the mentors be able to work with the students and be culturally aware of each of their students that they are with. Again, these students are taking the T's and SAT, so they have lots of tutoring with that to be able to apply for our nursing program. And then the students receive a weekly phone and email contact with their mentor. So it's really as if they have a parent. I like to think of it as a parent. Here's a picture of our reception with our cat, our NCAT cake, and then with awards for the students. What else do these students get in this program? Again, we've been fortunate that this has been from the HRSA Foundation through the government. They get $4,000 per year for stipend, or for their scholarship, $250 a month for their 10 months living expenses, which really, really helps these students. They have coordination of study time with their mentor and their pre-nursing advisor, and then they have career guidance from the mentor for nursing specialties. And this just shows quickly the variety of diverse students that we've had in the spring and the fall. Again, these are pictures of students from the reception. So it gives you an idea of the type of students. They're very young, 18 to 21. And again, the families. The mentors receive awards, as I mentioned, to create a bonding. And just to show 2 quotes, the mentor-student quotation. This program has helped me be prepared for the T's and critical reading tests. It has also helped me stay on track to apply to nursing and graduate on time. I have also enjoyed the support system that I have for questions and concerns. This December, we'll have our first 2 students graduate from the BSN program, and we're so excited about that. There's the mentors for the program, and there are a variety of people. We have 2 more that were not in this picture. A mentor quotation It is an honor being a mentor in the NCAT program. To be able to positively influence the lives of prospective nursing students is a rewarding experience. So this is all built on evidence-based strategies that's in the literature. There are now a variety of these type of programs in the United States, and right now I believe we have 14 of these type of programs. So to end up, our research focus for this program, and again, this is research, is our basic questions. Do mentors provide guidance for leading students to application success? And do students value the mentorship for leading them to apply to nursing school? So this gives you an idea of what type of programs are being established in the United States to help increase diversity. Thank you very much.
Good morning, everybody. It's really nice to be here. As was mentioned, Karen, my colleague, who is sitting beside me there, Karen Poole, the two Karens, we're from Lakehead University in Thunder Bay, Ontario. And we're here to share our findings from our preceptorship study that was done with nurse practitioner students and nurse practitioners. So. Okay, thank you. This is a picture of our campus in Thunder Bay. And just to acknowledge the people that were involved in our study, Andrea Raynack wasn't able to be in San Francisco today. We did receive funds from the Coupon Primary Healthcare NP program, and all the preceptees that participated, the preceptors, and our research assistants. So just to give you a little bit of an introduction, we have to kind of tone this down a little bit or pare it down a bit because we only have 15 minutes. So just the nuts and bolts is preceptorship is an integral part of the primary healthcare nurse practitioner program. Our students spend approximately 728 hours in preceptored experiences, so we really feel that preceptors are a very important part of educating the nurse practitioner students. When you look in the literature about preceptorship, you can find many advantages associated with preceptorship as well as some of the limitations. Some of the advantages include the ability to apply real-life situations to clinical practice, to experience the day-to-day relationships with patients and other professionals, the referral system, etc. And overall, it's been identified as an effective way of facilitating learning. When we look at the limitations of preceptorship, we often find that preceptors may be difficult to find and to retain. They work in very busy clinical environments. Sometimes the environments are not conducive to learning. There may be lack of faculty support to assist preceptors. Lack of compensation and lack of preparation are some of the ones identified. So our program is a 9-university consortium program in Ontario. So what that means is that within Ontario, there's 9 different universities that deliver the primary healthcare nurse practitioner program, the same program. So we wanted to do an evaluation of how preceptorship was working within our program because we knew what the literature said, but we didn't really have a good idea of how things were working within our own program. So we wanted to identify perceptions from both preceptors and recent graduates, which we call preceptees, to get more about their experience, to determine the facilitators and barriers. And from that, we developed a preceptorship workshop. This is the model that we used in developing our preceptorship surveys, our surveys that we're looking at our outcomes. And really how we used this conceptual model is that we wanted to make sure that there were variables included that could affect the preceptorship program that came from preceptors, preceptees, and the organizations. Our study was cross-sectional design utilizing survey methods. It was done completely online so that we could capture participants across Ontario from the 9 different universities. The recent graduates were preceptees who had completed the Ontario program within the past 2 years, and the preceptors were preceptors who had had students for greater than 2 years at any of the 9 consortium universities. So when we emailed the invitation to all preceptees and preceptors, we had an overall response rate of participation for preceptees of about 25%. So approximately 1 in 4 of our graduates did complete the surveys, and the preceptors about 26%. And there were a few email reminders sent to encourage participation at those rates. So just to give you a little bit of the findings, first of all, for the preceptees or the recent graduates, this is a few of the demographics that we collected. So approximately 30% had completed our BSCN, Primary Healthcare Nurse Practitioner program, where 66% had completed the master's degree with Primary Healthcare NP, and 3.9 or 4% had completed the DNP. They completed 2 surveys, one of which is called the Clinical Teaching Effectiveness Instrument, and here they could range items on the scale that range from a low of 1 to a 5 of high. Overall, when we looked at the information or the statistics, the range of scores range from 3 to 3.7. So when you consider that the highest score was a 5 and the range is 3 to 3.7, they were sort of in the middle, more to the positive, but not really high. Some of the high scoring items from the preceptor evaluation included that the students felt that the preceptor stimulated them to learn independently. That mean was 3.7. That they allowed for autonomy appropriate to the level and experience, 3.6. Some of the lower scoring items from the preceptees is that they felt that the preceptor clearly specified what I am expected to know and do during the clinical experience. So that had a lower mean of about 3, or adjusted teaching to my needs with a mean of 3.0. The other survey that we collected from the preceptees was the clinical learning environment inventory, and these responses ranged from strongly disagree, disagree, agree, and strongly agree. Some of the more positive responses were the preceptees felt that the clinical placement was interesting, 84%. The preceptor talked with me personally, 82%. Some of the negative responses from the preceptees to the statement, I look forward to the clinical placement. So 35% felt strongly disagreed or disagreed that they looked forward to their placement. The preceptor involved me in daily feedback sessions about my practice. 48% strongly disagreed or disagreed that they had daily feedback. So there were certainly some concerns out of some of this data that suggested that some of the preceptees had at least one negative experience with a preceptored clinical experience. We also asked open-ended questions so that we could get some more examples of what some of the facilitators and what some of the barriers might have been. And when we went through the analysis of the data, we came up with 3 facilitators and 3 barriers from the preceptees. Some of the facilitators included diversity. The students liked practices where there was diversity in patients, there was diversity in the sort of type of people that they were seeing. When the clinical environment was conducive to learning, had adequate space, that there was a time to meet with the preceptors, and when there was positive communication between the clinical preceptor and the student. Some of the barriers that were identified were time, very busy clinical practices. Also that they felt that there was unclear expectations. They weren't sure exactly what their role was to be there. And same with communication, that there were some components of negative communication. And I have on the next few slides some examples of some of the quotes from the participants. And I won't go through them all, but I'll just go through 1 or 2 and you can certainly read them. So in terms of diversity, some of the preceptees said that they really liked having things like a full family practice with patients from all ranges, walks of life, medical conditions, or very complex patients where there was lots of learning opportunities. In terms of the clinical environment, the setting and team were receptive to students and to the NPs. I was able to shadow other team members and explore other interests. So that was a real benefit to that student, that they were immersed in a positive learning environment. In terms of communication, this student said that the preceptor was supportive in discussing action plans and plans of care prior to entering patient room, which enhanced my confidence to management of chronic conditions. Or feedback about my practice helped guide my learning. The preceptees also spoke of time as being a barrier. And the quote here is that there was no time for dialogue or collaboration, no actual teaching or discussions regarding practice guidelines, advanced assessments, no critique of my practice, good or bad. And the unclear expectations. Some students felt I was provided with too much autonomy and not enough guidance. Observation and feedback on skills and clinical decision making was minimal. Or another student who said, I felt I was alone to fend for myself and given more independence than I felt I was ready for at the time. It was difficult to provide effective and efficient patient care, as there were times when the preceptor had actually left the building. Communication barrier, my preceptor was a poor communicator. It was like pulling teeth to get feedback or interaction from her. Or the preceptor was respectful and considerate, but she did not engage easily. Despite numerous requests for feedback, very little was provided. And in terms of the preceptors, a little bit of demographics about them. So approximately 30% had a bachelor's degree, 59% had a master's degree with primary healthcare NP, 5.3% DNP. There were 2 PhD prepared preceptors and 9 physicians. It was also interesting when we looked at years of experience that we had diversity in terms of some preceptors being quite new grads and other students having 10 plus years. The preceptors completed a clinical preceptor evaluation tool, the CPEET, and it looked at 4 different subscales. And the range on this scale is from 1, strongly disagree, to 7, agree. So when you look at the domains and the means, you can see here that the preceptors actually scored themselves quite high. Their roles questions, a mean of 6.43. Experience in education, again, a mean of 6. Satisfaction with their role of being a preceptor was very high, 6.42. And the one that was a little bit lower, although still 5 is quite high, is challenges, but sort of identifies that there are some challenges from time to time. I'm going to skip through this. The themes that were identified in terms of the facilitators and barriers to clinical by the preceptors were, I'll start with the facilitators, is that they really felt that the preceptors had positive qualities and attributes that they brought to the preceptor experience, which was beneficial, as well as the clinical learning environment. So many spoke about the preceptors feeling a need to give back to the students, a need to do something that another person had previously done for them. So I firmly believe that as a preceptor, I'm responsible to facilitate the student experience and provide a respectful environment in order to model appropriate behavior towards learners. The clinical environment came up again in the diversity, the same that the preceptee students said that they valued those learning environments that had a lot of different options for them. The preceptors felt equally that they were important. Space and time came up again and again. Adequate space for students to see patients, adequate time for them to do their full assessments, and time to debrief with the preceptor. The barriers, there was 4 identified, 1 being space, so not enough space and not enough time. Challenging students. So sometimes preceptors said that there were personality conflicts that could negatively impact a student's learning. As soon as it's noted, intervention needs to happen. Another commented on one student that decreased my satisfaction was with a student that was not open to learning, and they felt that they knew everything. There was no acceptance for the guidance and direction that was being provided to them during the time that they were present in clinical. Communication with faculty was another barrier that came up with the preceptors. Some said that they felt that there was more direction and feedback required from university faculty. They said that feedback is now what I ask for from each student, so I know how to enhance the clinical experience. Preceptors wanted better understanding of what to expect of students, so that unclear expectations that the student said was now coming up with the faculty. With the preceptors. And that it would be of great benefit to have a yearly workshop. Preceptors felt not knowing how to support a student who was struggling, so feeling like I was failing to meet the needs of the student. Remuneration was also considered a barrier. So our program does have a stipend or honorarium for preceptors who preceptor students, but some agencies allow the monies to go directly to the preceptor. Other agencies keep the money for the agency, and it may be used for professional development. So there's some tension there in terms of who gets the remuneration. So this is one example of saying sorting out the payment of the stipend is an issue across the province. There is a lack of consistency among placement site. Some preceptors are compensated and some are not. And I feel like preceptors should be cross-appointed with the school faculty of nursing. So those were some of the limitations from the preceptors. Overall, when you look at the study, there are some limitations of the study. One is that this study was specific to our consortium-based 9 universities and may not be generalizable to all other programs. We also used a convenience sample, so it may be that people that were either really happy with the program or not happy sort of put their thoughts in, and we may not have a broad representation of all sort of levels of satisfaction. And just a couple points on discussion. When we looked at our findings and we went back to the literature, these findings are well supported in the nurse practitioner literature. They're well supported in the nursing literature for undergraduate and graduate students, physicians. It's really not a lot of new information. And again, when you look at the literature, things like heavy workloads, lack of time, lack of orientation and training, which have all been identified as potentially hampering the clinical experience, they've been identified since 1997, and now in 2015 they're still being identified, really suggesting that perhaps we haven't done a good job at addressing some of these barriers or limitations. So many of the themes that have come up in our study are amenable to intervention, and so hopefully, I know for our institution, it is something that we are looking forward to, and looking forward to developing a task force and making some new roads in the future. So I thank you for listening to the presentation, and if there's a quick question, that's probably all we have time.
You do it.
Okay, I have a handout outside, as well as I'm giving pens to recruit some of you to be part of our university. I'm glad to be here and share with you my study, which is in working progress, study on caring and cultural diversity behaviors of students study abroad. It was great to be part of the study abroad program in our school, University of West Georgia Tanner Health System, School of Nursing, as I believe in caring principles. Caring is embedded in our School of Nursing's philosophy and vision. Personally, I'm also interested on how students demonstrate their caring and cultural diversity, because there was no study about that, and so it was my passion. So there are three objectives of these presentations. It's threefold. Describe the nursing students' caring behaviors and cultural diversity awareness. Discuss challenges as well as the benefits of study abroad program. Gaining an understanding of the global healthcare issues is one of the most common reasons for initiating the study abroad program. According to the study abroad website, U.S. has a total of 207 verified and documented nursing study abroad programs. In our school, there are 18 short and long-term study abroad programs and just one nursing study abroad program. It was initiated as an option for the clinical specialty practice. We have about 20 applicants per year and only 12 are taken, based on their scholastic record as well as their financial abilities. The minimum to take is 10 students with 2 nursing faculties or nursing professors. And here's the study abroad program. I was part of the 2-year, 2013 and 2015, but it was initiated in 2013. We have a partnership with the Semmelweis University in Budapest. So each year we recruit students who are interested to be in the study abroad program. It was fun. Okay, in our program components, it is in the May master, and I was again part of the 2014 and 2015. It is only about 23 days. There are 2 clinical faculties, and I'm one of them, or I was one of them, 12 students. The ratio is 1:6. The total is 24 students, 70% Caucasian, 100% female, and their age range from 20 to 30. 45% is about first-time traveler outside of U.S. It means that if they have traveled in Canada or Jamaica for a cruise, they are not considered as first-time traveler. The students were required to complete weekly clinical evaluation tool, daily journal, healthcare issue paper, discussion post, and 2 oral presentations. A typical day for us is waking up at 6 o'clock in the morning, take breakfast, and then we have to leave at the hostel at 7:30. At the clinical site, we attended and participated in lecture discussion with the medical educators, and we learned from them. The topics were history about Hungarian social and cultural context, as well as Hungarian nursing structure and situation, emergency situation, cardiovascular and intensive care nursing topics. In the afternoon, that's where we go to the clinical setting. We went to the 2 orphanages, to the military school, to attend to the pre-operative and post-operative and surgical setting, as well as the ICU and the CCU units. In some days, like weekends, and one of the 7 days, we have a sightseeing, and we were able to see the parliament, some historical places, as well as we went to Vienna and the Slovakia, where it's the neighboring countries. It's also time for relaxing in a weekend, as well as to catch up with our clinical paperworks. Okay, so the purpose of this study is to relate the students' caring and cultural diversity behaviors as documented in the clinical evaluation tool. So the research question is, what are the caring and cultural diversity behaviors that the student demonstrated in their clinical performance while in the study abroad program? I'm a visual person, so I want to share with you the clinical evaluation tool that I got this information from. The students have to rate themselves here from 0 to 3, 0 being not demonstrated, 1 as needs improvement, 2 meet expectations, and 3 exceeds the expectation of safety, education, informatics, competency, communication, teamwork and collaboration, critical thinking and reasoning, but I'm more interested with the caring, holism, and cultural diversity. I deleted the holism because all of them did not really say anything about holism, so I'm more of the caring and cultural diversity. This part where there's a big gap, that's where they type their narratively how they demonstrated the behaviors. So for the caring part, I categorized them into 2, the nonverbal behaviors as well as the verbal behaviors. For the nonverbal behaviors, they said, I have touched, held their hands, comforted them by means of hugging, smiled at them, prayed for them, shared my food with my peer, stayed with each other, listened to whatever they have said, and helped them in carrying heavy loads. For the verbal behaviors, they responded in their own language, the Hungarian language, said thank you and let them know that they were appreciated in a simple gestures. They asked for clarification for what was said, and they apologized for not understanding the language. For applying new knowledge and skills, one said, I was able to culturally immerse myself by successfully learning the transportation system and responding in basic Hungarian phrases. The second one said, it was inspiring to learn a dance that represented the Hungarian heritage. And lastly, appreciation of complexity. I'm grateful that we live in a place that allows us to express opinions and freedoms I have in my country. I am adjusting well to some of the culture shock I have been experiencing. I'm really starting to appreciate a culture other than my own. So the challenges that I have read in their journal were, I just summarize this with CHALLENGES. Cultural issues such as the transportation and money exchange. For the transportation, it took us, well, some of them will say, well, okay, how many miles we are going to walk, or how many minutes? And they said, well, just 10 minutes. But for U.S. nursing students, it took us 30 minutes for the few days that we were there, because we were not accustomed to walking, we were driving. And then we have to find our way to go to the subway, to use the train, and also the tram or the metro. And then again with the money exchange, because that was the first time to exchange money from dollar to forints, which is the Hungarian money. And it was 219, and they said, oh, wow, we are rich. And they said, oh, no, you're not really rich because it's the same expenses, okay? For homesickness, being away from family, the only solution for that is going to McDonald's, Burger King, or Pizza Hut. And then they are happy as can be, or they're peaceful. Okay, I said, we'll go to the Burger King right now and just melt down. Okay. There's also the airline issues such as the baggage, immigration, as well as the ticketing. There's the language issues, the accent, and even for me, there's an Asian accent, there's a Southern accent, and for them, there's a new words that they have to learn. That's kusunam, which means thank you, and those are the words that they keep on saying it and practicing it while they were there. There's also the loss in environment, because going back to the hostel, we have to walk 2 miles and then ride in the subway, that's I've said in the transportation. For the end, there's no 24 hours Wi-Fi or internet connection. And, by the way, we have to have a international adapter. Yeah. Gastronomic indifference says the food. We have to learn how to eat what they serve us. And the most popular food that they have served the langos and goulash. And you can see the spaghetti with poppy seeds. And when they saw that and said like, oh, what is this? And they said, well, it looks like grass, but then it is actually poppy seeds. Then they have to learn how to eat it because it's our lunch, or else they will be hungry. So the interesting information that they've learned is that pepperoni is a green spicy pepper, because when they ordered pepperoni pizza, guess what? The salami wasn't there. It was a pepperoni. No, I ordered pepperoni pizza. No, this is the pepperoni pizza. It's a spicy pepper. And so, okay, then you have to eat. That's what your order is. Okay. Most beverages do not contain ice. Need to order lemonade, because in Georgia, where we were, is that all the iced tea, it's bunch of ice. Okay, and so only half of it is the tea itself. Salt is common at the table, pepper is not. Gelato shops are located every corner, as well as vegetables are commonly fried. The fried cheese is an alternative to meat. The drinks, we have to learn that there are 3 types of water. The sparkling water, the non-carbonated water, as well as the moderate in between. And guess what? We have to learn how to drink palinka. And it was the first day that they offered us palinka, which is the fruity brandy. And I didn't know that it's really an alcohol. And it tastes like rubbing alcohol, and it went into my stomach, and I said, oops, that was like burning. I said, oh gosh. But I cannot say no, because that will be, not a good gestures for them. Okay. Anyway, the E is expected multiple responsibilities, being in the 4 students in one room. They have to deal with their roommate, and they have to deal as a sister. The S is a synchronous time, because there's a 6 hours difference from Hungary and the USA. The benefits, B stands for boost morale, E, educational partnership and networking with professionals, E, experiential learning, F, fun-filled trips, I is international interest vested, T is travel with less expense, and lastly, spectacular, memorable life experience. That was the first time I have experienced fish pedicure as well as thermal bath, and it was really relaxing. It was worth it. Okay. In conclusion, students are able to demonstrate caring and cultural diversity behaviors in different environments. Study abroad programs facilitate the students' appreciation of the universality of caring and cultural diversity. Benefits outweighs challenges, as well as to recommend to initiate study abroad program. These are my references, and any questions, I would love to have that, so you can have the pens and those two.
students who attend those therapeutic debriefing and reflective discussions that we all like to have with them in the clinical areas. As nursing instructors, we have the students in clinical areas after they've spent a day on the units. We usually meet with them afterwards, right, to have a little bit of a post debriefing session. So this is something that I've been trying to inspire the students and refresh the students so they can have better discussions with us. It's a participatory type of presentation, so I'm going to ask you if you wouldn't mind to put down your cell phones possibly and close your laptops, and I've got some things for you. I'm just going to pass these out to different groups. I'll do some. Would you like to try? And I'll be collecting these afterwards. Another group would like to try over here.
Yeah.
Who else would like to try? Over here? And I've got anybody over here would like to try? You can pick whatever one you want. And I've got one more set. Okay, so while I'm speaking, just feel free, the people who are participating, to just pick one of these designs and just pick the colors that you want and just go ahead, go at it. Okay? So ideally, nursing instructors in the clinical setting set aside time at the end of the day for the nursing students to share information and analyze situations that have occurred during the day. And instructors also use this time for what's called therapeutic debriefing and reflective exercises. And what we really want to do is draw our students' attention to what's been happening during the day, the relevant information, and help them understand their experiences. Does this resonate with people, this kind of clinical debriefing session? Okay. But in reality, it's often difficult for us as instructors to consistently promote reflection and introspection in our students because often they're very, very fatigued when this kind of post-conference occurs. They often report lack of sleep or poor sleep before the clinical because they're really anxious about the clinical experience. They sometimes feel that we're going to reprimand them in front of the other students, or they're concerned about the fact that if they talk, they might reveal that they have a lack of experience or ability. Some of them feel very pressured and overwhelmed, so they just don't want to talk. And although we might perceive that our relationships with the students help them to talk with us, often the students are really just focused on the instructor's evaluative role, and they're just really interested in being evaluated highly, and that's sometimes the only reason they'll talk is because they're being evaluated during these discussions. Have you ever noticed that moments of inspiration often occur to you when you're trying to answer a difficult problem and you're driving or showering or walking around, and all of a sudden when you're not really deliberately focused on that difficult problem, the answer will occur to you? Have you ever noticed that? Have you ever noticed when you feel less pressured to be expansive and insightful or solve problems, or generate original ideas. You feel more creative when you're less pressured, and you can think better when you don't have that pressure to solve a problem. Well, researchers from the diverse fields of psychology and neuroscience have also observed this phenomenon. Researchers have observed that when people are provided with a period of rest and they become occupied in a simple, distracting task that's not too cognitively demanding, they'll often find creative solutions to problems compared to people who are not occupied at all or occupied in a demanding task. And researchers call this phenomenon mind wandering. We can use the concepts of rest and mind wandering to refresh and inspire undergraduate nursing students and enhance their capacities to reflect and generate ideas when we have these post-clinical discussions. The goal of the coloring is to just distract the students just enough to occupy their conscious attention so that their divergent, less accessible ideas are allowed to surface during the discussions. These ideas are associated with regions in the brain that are most active when the brain is allowed to rest and wander. And scientists have used neuroimaging techniques to actually show these areas of the brain that are associated with more creative ideas. And this is called the default network. So this is not just something that we have just created and made up. This is actually scientifically observed. Researchers have found that the default network overlaps considerably with moral judgment regions in the brain and reflective regions. Moral reasoning and thinking and reflecting, thinking about what happened and what could happen the next day, these are exactly the skills that we want the students to achieve during their reflective post-clinical discussions. Wouldn't you agree? So in our nursing school, we've offered students a period of rest called an incubation interval in combination with an unrelated distracting task, that's this coloring task, that has a light cognitive load. The intervention is aimed at preventing their constrained or focused concentration on their instructor's prompts to allow their creative and less accessible ideas to surface. The complex coloring pages for adults are the unrelated distracting task with the light cognitive load. And we've invested in a variety of gel pens and pencil crayons and fine markers. And these are the things that I've given you today. Although the gel pens and markers are expensive, and I will be collecting them afterwards, if that's okay with you. They're very expensive, but you'll notice the people, especially who have the gel pens, that the colors flow very easily and they feel luxurious and they result in quality end products. And it's important for us as teachers to make an investment in something that's nice for the students to use rather than some cheap pencil crayon. I have some pencil crayons, but so they have a choice, but they really like these gel pens, and I'm sorry if some people have pencil crayons and other people have the expensive gel pens. So the investment rests on two fundamental assumptions. The activity is important enough for us to invest in quality art tools, so we really don't downplay this activity during our discussions. And the activity is planned to meet adult students' needs and expectations, so that's why we invest and spend money on this. The process has to be undemanding, self-paced, and repetitive, so students shade. It's important that they shade, but they do not draw freely because that's too cognitively demanding. Free drawing is not repetitive enough, so you'll notice that all of the designs and things that I've given you are kind of repetitive. They've got different repetitive shapes, and that's important. The design that you pick has to be fairly repetitive because that's how the brain works the best. So this year in a multi-site study, we are going to use a randomized crossover research design to actually test this intervention. We haven't done it yet, but we've applied for funding to do this. And I just want to point out this photograph here. These are all my photographs of my students' art and my students doing this during their discussions with me. That male students also participate in this. They don't have to participate. Nobody has to participate. I don't mind if they don't. I just put it out there. I just say, this is something that you might enjoy. Other students have enjoyed this too. Here's something that you might enjoy while we have our discussions. So there's a male student doing this as well. I just put that photograph in there. And these are students after clinical, so you can see the stethoscope sitting there, and we're having a discussion. And we might be having a discussion on anything. Somebody dying during that day, or some other sort of issues, really big issues. And they're doing this while we have the discussion. So in our study that's coming up, we're going to have 145 students in 16 clinical groups. 8 groups will be assigned to this coloring, and 8 groups will participate in the usual post-conference for the usual length of time, and after 6 weeks, the groups are going to cross over. All students are going to complete 3 instruments at the beginning, midpoint, and end of study, and some basic satisfaction scales. We hypothesize that participation in post-clinical conference discussions is a planned behavior, and so the students think about this ahead of time. They think, well, I'm going to participate in the discussion with Elizabeth, or I'm just going to sit back and I'm not going to participate. So we hypothesize that it's a planned behavior, so we have used the theory of planned behavior to frame our study. And we're going to complete a theory of planned behavior questionnaire, plus a brief fear of negativity evaluation scale. The fear of negative evaluation is a known constraint why students don't participate in post-conference. The BFNE2 contains 12 positively worded items and demonstrates high reliability. Then we have a positive and negative affect questionnaire, which is a reliable measure of mood. High positive affect is a state of energy and full concentration and pleasurable engagement, and that's what we want to happen in the post-clinical discussions. And high negative affect is characterized by displeasure and avoidance. And then, of course, they're going to have a basic satisfaction rating of the clinical discussions on a semantic differential scale, and we're going to collect the demographics of the students and instructors as well. In closing, nursing practice is characterized by increasing specialization and heightened use of technology. Would you agree? Nursing students learn how to be technologically proficient and accurate and competent in their psychomotor skills, and flexible and adaptable. But equally important, nursing students have to maintain a humanistic commitment to attending to the concerns and needs of others and we concentrate on this when we have our reflective post-clinical discussions. That's what we talk about. These types of discussions are designed to draw their attention to relevant information and help them understand their beliefs and experiences. But we cannot impose these kinds of discussions on them. I've tried everything with students to try to get them to talk. I've had candles, I've had food, I've had some sort of meditative thing going on. I've tried lots of things, and this is the only thing that I have found that really, really helps them to talk. So the next step is to gather empirical evidence to see if this is really working for the satisfaction and the fear of negative evaluation, and if they're planning their planned behavior, that kind of thing. I want to point out, just before I finish, that I have used this with graduate classes. I teach graduate classes and in a master's program, and we have a lot of philosophical discussions in these classes. And I have brought out these things, and they've been shocked at first, and I'm sure you're probably a little shocked, but they sit down and they do this, and I found that they can come up with a lot more creative and philosophical ideas when we're doing this in our discussions with graduate students. So it's not just undergrad that I have used this. The students also seem to enjoy the discussions a lot more. And I've also noticed that when we're talking about something that's difficult, like say somebody dying or somebody in the dying process that they've looked after that day, they don't have to make eye contact with me. They can look down, they can be still coloring, and they can be talking to me about their feelings, and they don't have to bring their eyes up. And that is a really good thing that I have noticed that works well. And it's also considered to be a boundary object. So when I put all the pens, the gel pens, and the paper on the table, they have to share these and say, well, what are you doing? And, oh, I would like that piece of paper. And this is a sharing activity, so it generates a lot of just social things, social relationships as well. So that's the end of my presentation, and if you have any questions, please let me know.
I love the idea because I always toy with structure versus non-structure in post-clinical conferences. If I present a case study, they may have their attention for 5 minutes. I do find, as you
Like
said,
that, yeah.
right, or they're so tired.
Yeah.
But I do find debriefing on just the experiences of the day probably as one of the best ideas, reflective thinking.
Mm-hmm.
How did you feel about that? How did you feel when the nurse said that? Or, you know, and I think you can't put a label on that. I mean, it is reflective, but again, I appreciate your insight, and I can't wait to see your results.
Thank you.
Thank you. That was very interesting. I just saw a special on the television where they have adult coloring groups.
Yes, that's right. So the other thing is nursing instructors don't have to feel that you're breaking copyright, because there's plenty of free sites. I got all of these from free sites on the internet that you can download free pages. Just as long as you make sure that you download the ones that are kind of repetitive, like the Mandela type of things. And it's becoming very popular. It's a relaxation technique. Yeah, I agree. Yeah.
Okay, so is Naomi here at the moment? Thank you, Naomi. So Naomi, to TC.
To TC. I'm a PhD student, so I feel very privileged to be here in your company today. This is a fairly new experience for me, so I'm embracing it. And I'm from the University of Queensland in Brisbane, which is the capital city of Queensland, which is one of the states of Australia. So Brisbane is about 1.5 hours north of Sydney, you've probably heard of, and about 2 hours, flying time, I should say, and about 2 hours flying time south of Cairns, which you've probably heard of with the Great Barrier Reef. So that's where I come from. My title is a bit long, but hopefully what I'll be saying today is more succinct and short. The presentation today is about my pilot study, which is a precursor to my main study, which is a 3-arm intervention design examining student facilitation of debrief after high-fidelity simulation and its impact on critical reflection. So I was really interested just to hear with what Elizabeth was saying about reflective thinking, particularly in a clinical placement setting. And certainly I think I'm going to have to go back and read some more literature, which is great, on such an innovative approach to facilitating reflective thinking, because it is a very abstract concept for most of us to get our head around. I'll explain typically what a high-fidelity simulation is. I think you probably all know, but it is a realistic and interactive clinical learning experience which finishes with the reflective debrief, usually facilitated by an academic. So my study is different in that I'll be getting students to facilitate the debrief, which I think will address some of those issues that Elizabeth raised about reticence to speak, and certainly the literature supports that. It creates quite a positive learning environment, and certainly sitting through about 80 simulations as part of my study, I found when the students were facilitating the debrief, the other students tended to be more relaxed and willing to disclose. So my pilot study is aim to determine the reliability and validity and content validity of 2 instruments which form part of the survey on reflective thinking and simulation. And why these 2 parameters? Well, I actually modified those 2 instruments, so I needed to establish content validity and reliability. Now, the first instrument was designed by David Kemba and his colleagues to measure reflective thinking in professional practice courses. So it wasn't actually designed specifically for nursing and high-fidelity simulation, hence the requirement for modification. And the second scale I pinched and modified was designed by K-Meg, and she actually came up with a visual analog scale to measure the self-efficacy of communication. This is my second favourite person in the world after my husband, and I was so excited to see him in San Francisco a couple of days. I couldn't believe it. So this fellow is the Thinker, a 70-metre sculpture. He's a very imposing figure of intellect, and he was actually created by Rodin as a heroic figure in the tradition of Michelangelo. And as I said, I was lucky to see him. He though, isn't the original. He's one of 3 that have been cast and, I think, sent around the world. So I couldn't believe it when the tour guide brought us into the Legion of... I'm not sure where it was. I saw so many sites that day. Anyway, the ability to critically think, and I'm talking about critically thinking now, is still it's highly valued and considered a fundamental skill to be possessed by an undergraduate. And it is listed in my university's core competencies for a graduate skill. It's a generic skill, it's a cognitive skill, and it's characterised by purposeful self-regulated judgment. Now, there's copious articles written about critical thinking nursing, and it's important in facilitating the graduates' transition into practice and to help them function effectively in this rapidly changing world that we live in. Now, like anything, practice makes perfect, and by flexing your critical thinking muscles as an undergraduate, or when you were an undergraduate, it is an important part of your academic training and professional development. Now, I'll briefly elaborate on the link between critical thinking and critical reflection. So what does the literature tell us about critical reflection and critical thinking? Well, it says to be able to critically think and enjoy all the benefits of this skill, you need to be able to reflect, and in particular, critically reflect. Critical reflection is a metacognitive skill which enables individuals to examine themselves and their surrounds and affect change. So it's actually about that affecting change in your environment and within yourself that differentiates reflection from critical reflection. There is a consensus in the literature that high-fidelity simulation is an effective teaching and learning methodology when adhering to best practice. And it's associated with clinical reasoning, which we heard a bit about yesterday, namely critical thinking, clinical skill performance, and knowledge acquisition. Now, René Descartes, I'm not sure if I pronounced that correctly, a rationalist philosopher, famously stated, "I think, therefore I am." And this, rightly or wrongly, connected in my mind with Bandura's social cognitive theory, where people's level of motivation, affective states, and emotions are based more on what they believe than what is objectively true. So, crudely put, if you believe you can do it. So I wanted to explore this premise. If a student nurse believed they can critically reflect, Will they actually do that? Now, the literature supports the role of self-efficacy and its evaluation and simulation, and it's known to enhance both learning and self-confidence, and that's probably a fairly well-established phenomenon now. So, what was not spoken of in the literature? And that's the one thing I've probably been learning as I go through my PhD journey, is to find that gap, and hence the gate. Where are the gaps? And now many educational courses aim to promote reflective thinking. We hear about reflective practitioner, or reflection upon practice, which is a skill more associated with the undergraduate. But there is a scarcity of relatively usable instruments to determine if students engage in reflective thinking, and if so, to what extent. Do they reach the highest level of reflective thinking, that is critical reflection, or are they more at that habitual action and understanding level of the scope of reflective thinking? Additionally, what is also lacking in the literature is the measurement of self-efficacy or self-belief about one's capacity to critically reflect, and how the relationship between self-belief and critical reflection impacts on learner satisfaction and learning outcomes. So, the questions I then asked myself were, can undergraduate nursing students by the end of their third year nursing degree critically reflect, and at what degree of self-efficacy for critical reflection do they report? To determine the level of reflective thinking and self-efficacy for critical reflection, the focus of the pilot study was described by these two questions. Does the reflective thinking instrument and critical reflection self-efficacy visual analog scale demonstrate content validity? And what is the reliability of the reflective thinking and simulation survey? This pilot study intent, as I've mentioned earlier, was to determine the reliability and content validity of these instruments not previously tested or used together. So to achieve this end, the study was divided into two phases. Now, phase one used individual think aloud sessions and then an expert panel to address the validity measures of these previously untested instruments. And then phase two used a post-test only design to address the reliability measures of all the instruments used in the reflective thinking simulation survey. A metropolitan Australian university, that is the Queensland University of Technology, was the setting for this sample. It's one of the largest schools of nursing in Australia with approximately 2,500 nursing students, and we offer a Bachelor degree in nursing and 3 double degrees for nursing behavioural science, nursing paramedic science, and nursing and public health. The high fidelity simulation laboratories are located on site, and the study was undertaken between August and September last year. Now, all the Bachelor of Nursing students in their final year of study, undertaking their final clinical unit, were eligible for this study. And the students were recruited to both phases by announcements and a 3-minute vodcast shown on the learning management platform system and emails as well. And the announcements were staggered over a 5-week period leading up to each of the phases. The Phase 2 survey was comprised of 5 instruments, as well as demographic questions and an open-ended question. Now, I'll briefly describe each instrument, and I'll try and be brief. The reflective thinking instrument, the one designed originally by Kemba, consisted of 16 items using a 5-point Likert scale. Now, interestingly, he had gone for the hierarchical approach to reflective thinking, so there were 4 subscales, that is, representing 4 levels of reflection: habitual action, understanding, reflection, and critical reflection, with modified content from phase 1. The second instrument, the self-efficacy for critical reflection visual analog scale, measured how certain participants felt they could critically reflect after clinical practice, and was a straight line with 0 representing cannot do at all, while 100 represented highly certain can do. The third instrument, the general self-efficacy scale, which is widely used, measured a global confidence in coping ability across a wide range of difficult or demanding situations. It consisted of 10 items using 4-point Likert scale. The fourth instrument, the Educational Practices in Simulation Scale, which came from the large study done by Jeffries and Rizzolo, consisted of two 16-item scales. The first scale used a 5-point Likert scale and not applicable column, and it was designed to assess the educational practices associated with simulation, and the second scale used a 5-point Likert scale for those same 16 items from the perspective of how important these practices were to the participant. The scales measured 4 areas of educational practice: active learning, collaboration, diverse ways of learning, and high expectations. The fifth and final instrument is the Satisfaction with Simulation Experience Scale. It consisted of 18 items on a 5-point Likert scale, and items were grouped into 3 subscales: debrief and reflection, clinical reasoning, and clinical learning. And the survey contained an open-ended question to seek comment on the simulation experience. Phase 1 commenced with individual Think Aloud sessions and took place after a high-fidelity simulation. Participants were asked to complete the reflective thinking instrument and visual analog scale whilst talking out loud about the questions, and it was quite an interesting process to go through. They completed each instrument on a laptop computer, and responses were audio recorded. Content validation of these 2 instruments then followed by expert panel. And the expert panel consisted of 6 academics to ensure sufficient level of control for chance agreements. Now, these academics had a mix of expertise in high-fidelity simulation, reflective practice and instrument design, along with expertise in curriculum design to accommodate international and domestic students. And this was done to provide both content and context expertise. And the panel members were provided with working definitions of the study's primary constructs, along with paper copies of the modified instruments. Phase 2 followed after phase 1, obviously, and with survey modification and review of content validity completed, the 2 instruments were then inserted into the reflective thinking and simulation survey, which was a compilation of those 5 instruments. And it was distributed electronically via an online link, and I used Key Survey, which is a QUT product. The survey remained open for 2 weeks once the final clinical subject simulations had been completed. The first step in phase 1 data analysis was verbatim comment analysis and grouping of similar responses from the individual Think Aloud transcripts. Then the expert panel rated each item of the modified reflective thinking instrument and visual analog scale using a 4-point Likert scale. And additionally, comments were sought on each individual item to reduce question ambiguity and to provide new perspectives. The index of content validity was applied to the modified reflective thinking instrument and visual analog scale. An averaging calculation method for scale, CVI, was used, and it is the proportion of items on an instrument that achieved a rating of 3 or 4 by all content experts, and this level should be set at 0.90. The 2 instruments were then combined with the other 3 into the reflective thinking and simulation survey and administered to this sample of students in their final year of study. The survey was used, as I said, in a post-test role after the participants had completed a simulation debrief. Phase 2. Phase 2 tested reliability using Cronbach's alpha, which was measured for the reflective thinking instruments, 4 subscales, and total score, and the alpha value was set at 0.7, and that's to demonstrate good internal consistency. The relationship between critical reflection self-efficacy and general self-efficacy was investigated to determine reliability, and I used the Pearson product moment correlation coefficient. And verbatim comments from the open-ended question in the satisfaction with simulation experience scale were allocated to groups based on the similarity of their content. Results, phase 1. Oops, just lost my place. Phase 1's results encapsulate instrument modification and content validity. Now, 6 students participated in the individual Think Aloud sessions, 5 females and 1 male. Their responses were gathered into 3 groups with these headings: thinking reflectively, Simulation equates to clinical practice, which I thought was an interesting response, and simulation-specific comments. Only a few responses referred to simulation directly, and I'd asked them to think about the simulation experience they'd just completed prior to undertaking the survey. But in most other instances, they referred to simulation as clinical practice. Therefore, the questions were altered where necessary to refer to clinical practice as the context for the participants' reflective thinking. The CVI results from the expert panel showed that the average proportion of items rated as relevant across 6 experts was in fact at 0.9. Now, no items were rejected by the expert panel, and comments by members led to 8 changes to the instrument's items. Okay, thank you. Phase 2 results. 58 third-year undergraduate students from a cohort of 231 participated in Phase 2. The majority of the sample were female and domestic students. Internal consistency of the reflective thinking instrument was sufficient across the 4 subscales and the whole instrument, showing good internal consistency. However, item 3, which belonged to the reflection subscale, had a low value for the corrected item total correlation. So it was removed to improve Cronbach's alpha from 0.608 to 0.722. The relationship between critical reflection self-efficacy and general self-efficacy to determine reliability showed a small to medium positive correlation between these 2 variables, with high levels of critical reflection self-efficacy associated with high levels of general self-efficacy. The remaining 3 other instruments, they all demonstrated sufficient internal consistency as well. Before I just briefly go into the discussion, I'll just say too that of the 58 participants, 22 commented on their simulation experience as part of the satisfaction with simulation experience scale. The responses were allocated into 3 distinct groups: simulation design, simulation experience, and simulation implementation. Overall, the participants' response was positive about the simulation experience. They described the simulation as helpful, excellent, educational. Recognition of its positive impact on the ability of simulation to foster learning. It was recognised by some participants that they didn't seem to value the experience as positively. Rather, they saw it as a university strategy to increase hours of study in place of clinical practicum hours. By that I mean actual clinical placement in the hospital. Simulation design, that theme, continued this constructive dialogue as it focused on the lack of variety of scenarios provided and the impact of length of debriefing on learning. They would have preferred debriefing to be longer. To summarise, the pilot study determined there was valid content and internal consistency for these 2 instruments, and with a small to medium correlation between the visual analogue scale and general self-efficacy scale. Now, measurement of reflective thinking and self-efficacy for critical reflection are under-researched in the area of simulation. So this pilot study, I hope, will assist with the evaluation of this metacognitive skill, which is quite difficult to evaluate because it's quite abstract. And also to have a better understanding of the link between self-efficacy for critical reflection and the transferability of competence into the workplace. A limitation of the study was the omission of the not applicable option for an item in the educational practices in simulation scale. This question was retained in the analysis for reliability. However, for a further validation of the survey, the item would need to return to its original form. Now, as I've mentioned, a small to medium correlation was found to exist between the 2 variables, visual analogue scale and general self-efficacy scale. So testing reliability of this instrument would be recommended on a larger sample and perhaps by finding a tool that was a closer substitute. And of course, self-report and convenience sampling can introduce bias into the data. And what I wouldn't have done then, knowing what I know now. to improve the Cronbach's alpha score for the subscale reflection in the reflective thinking instrument, I did remove item 3 to lift that score. However, as a consequence, I can't compare the results from this instrument now with results from studies using the original version by Kemper and colleagues. So it has limited that comparison. But I did it to make it a stronger, more reliable instrument. So it's a difficult one, and the benefit of hindsight, and it's a learning experience. So thank you very much for your time, and I'm not sure if there's time for questions.
Yeah, time.
Oh, okay. Yep.
Are there any questions?
Agreed?
Go ahead, Jane.
Oh.
What was the actual simulation activity that they performed? Or what was the exercise?
It was a man that had a motor vehicle accident and had sustained a hemopneumothorax and had a underwater seal drain inserted. And so the main crux of it was acute pain management and management of the underwater seal drain, which they'd had tutorials on leading up to the simulation. So it was actually interesting just watching them manage the drain. Some found it quite confronting, and dealing, because we're on the mic as the patient behind a glass window, and dealing with that acute pain. They found it quite difficult. And the communication, listening to the therapeutic communication kind of deteriorate as the pain increased. So they were sort of they had to pick up cues as to what was happening clinically. And then so that's why the debrief follows. Is that answering the question? Thank you.
Time for one more brief question.
I'm not sure about the brief one. I'm just wondering about the abstract concept like critical thinking. Has there been any evidence of undergraduate students achieving a level of critical thinking that you're talking about? And is there any objective measure to say that they have achieved critical thinking? And is critical thinking context-based? In other words, you can be a critical thinker in this context, but not in a different context.
I don't know if I can answer the last question, because I probably haven't read into that area. There are tools available that can measure critical thinking directly. However, I wanted to go the back route and try and quantify reflective thinking in this context of practice. So by that, then I could hopefully say, because they're critically reflecting, or at least reflectively thinking, they're then probably critically thinking as well, because we place a lot of emphasis on them being preparing them to be a reflective practitioner, and being able to reflect on action as an undergraduate. So as a responsibility as an educator, I think it's important to give them as much feedback as possible, and to validate the importance of being a reflective practitioner. So we need to give them as much specific information about how they're going with that skill. So I probably haven't answered your question, I'm not sure, but I can talk to you about it later anyway. Thank you. It got me thinking.
Thank you.
Thanks, Sam. Thanks, Sam.
That's for you.
Thank you very much. Do you want me to, are you right to get off?
Okay, so our next speaker, I'll just get my glasses.
My English is very, very horrible. I think of yours, and this is the end of the morning, just before the lunch, a bit of French It's very, very interesting. Good exercise for you. You read in English, you listen in French. It's good for the brain. It's good, very good. You have the translation. It's more easy. Read, listen. Who understands French in the room? Wonderful. Wonderful. En fait, en droit français, under the law, French law, les professions de santé s'organisent en 3 catégories. First, les professions médicales. Medical profession, which include docteurs, qui sont les seuls à pouvoir organiser des transferts de compétences. Il y a aussi les sages-femmes, particularité française, qu'on ne retrouve pas dans d'autres pays. Il y a aussi les dentistes. Il y a par ailleurs les pharmaciens, autre catégorie. Et puis, les auxiliaires médicaux, which include the nurse. Don't forget all along my above that in French, it's cure culture and not care culture. It's cure practice and not care practice. Le transfert de compétences, finalement, dans la loi française, n'est pas directement reconnu. On utilise le terme de coopération, cooperation with professionnels, tout simplement car nous avons un problème juridique. Tout simplement parce que penser en termes de transfert de compétences suppose de redéfinir les relations entre docteur and nurse. Pourquoi nous parlons aujourd'hui de transfert de compétences? D'abord pour une question de démographie médicale. We have a problem of demographic medical. Et in response, the government proposed to organize transfer of power. Le développement est finalement essentiellement dû à un changement épidémiologique. Le développement des maladies chroniques, le vieillissement de la population. Et puis aussi le fait que nous avons de plus en plus de technologies. Le transfert de compétences est en fait une réponse en amont, upstream, en aval, of medical intervention. Premièrement, dans une logique d'accès aux soins. Deuxièmement, à l'hôpital, pour des soins techniques. Troisièmement, up and down. I think in psychiatry. Le transfert de compétences, in this, suppose finalement une nouvelle organisation des soins, de nouveaux modes d'exercice, des nouvelles fonctions de coordination et surtout des métiers intermédiaires between doctor and nurse. En fait, comme partout, c'est un débat entre spécialistes, confisqué par les spécialistes. Nous avons fait, en France, la première enquête qui nous dit que, finalement, le public ne sait pas ce que c'est. Il est directement concerné, mais il ne sait pas ce que c'est. Une petite minorité peut avoir une idée de ce qu'est le transfert de compétences. Finalement, 16% de la population pense avoir une idée de ce qu'est le transfert de compétences. Nous réfléchissons à une nouvelle organisation des soins et une petite minorité de la population sait ce dont il s'agit. La très très grande majorité n'est pas au courant. C'est là qu'il y est intéressant car il y a une opposition entre ceux qui acceptent le transfert de compétences et ceux qui le refusent. Ceux qui le refusent pensent que les docteurs sont mieux formés à la base, ont une plus grande expérience et ont des formations complémentaires. On voit bien que la différence historique entre les médecins et les infirmiers perdure dans l'image auprès du grand public. Et même si le transfert de compétences pouvait régler des problèmes comme le coût des soins, l'accessibilité, il y a pourtant un refus de la population, une opposition. Ceux qui sont d'accord le sont sans enthousiasme. Quand nous regardons bien, on voit bien qu'il y a une contradiction entre ceux qui, finalement, pourraient bénéficier du transfert de compétences, les vieilles personnes isolées à la campagne, avec des petites ressources, qui, elles, restent très attachées au docteur, et pourtant c'est elles qui en auraient besoin, et ceux qui sont favorables, les jeunes personnes qui vivent dans les villes avec des bons revenus, qui, eux, sont favorables au transfert de compétences. Donc on voit qu'on a une contradiction, peu d'informations, pas de grands enthousiasmes, un accord plutôt du côté de ceux qui n'en auraient pas besoin et une opposition du côté de ceux qui en auraient besoin. Le gouvernement français prépare une nouvelle loi qui vise à reconnaître les pratiques avancées et à passer finalement du cure au care, ce qui en France est une très très grande avancée. Les pratiques avancées sont toujours par délégation médicale. On est toujours dans l'exercice infirmier par délégation médicale. On élargit bien sûr le champ d'intervention. Vous voyez que dans le cas des pratiques avancées, ce qui est prévu par la loi permet un exercice relativement large. Finalement, c'est une nouvelle organisation. Un problème de démographie médicale, une nouvelle relation entre les docteurs et les infirmiers pour déboucher sur une nouvelle organisation. Et autre élément important par rapport au contexte français, c'est que la formation infirmière va passer à l'université. J'ai écouté beaucoup d'entre vous, c'est assez évident pour vous. Là aussi en France, c'est une grande évolution, très très grande évolution. Mais toujours, always, submit notice of the National Academy of Medicine. Toujours sous contrôle médical. C'est un changement radical en France pour les infirmières, mais surtout pour les malades. Pour l'ensemble des activités, dans un monde qui, lui, va énormément bouger. Énormément bouger. J'ai entendu depuis ce matin, et hier aussi, beaucoup de recherches. Nursing research. En France, c'est très très pauvre. Très 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 pauvre. Et donc, il est extrêmement important d'avoir une formation à l'université, d'avoir après des doctorats, et d'avoir un exercice nouveau qui permet de basculer d'une logique de cure à une logique de care. Thank you very much.
Thank you. So,
Okay, so we did actually do the second part to this research yesterday, but this is the initial study that was done, and again it was done within the Bachelor of Nursing program at Wintec in New Zealand, and I'm sure you remember where that was on the map yesterday, that small country underneath Australia. So just a little bit of a context, and it's one that several of the speakers have alluded to. And Hinchell raised the concept of the perfect storm, which is talking about a time in nursing history where, due to such things as a depressed government economies and depressed nursing budgets, government budgets, nursing faculty shortages, and actually nursing shortages, have all collided to create it's quite a fragile clinical environment in terms of nursing students. It's impacted on the fact that sometimes it creates, the situation creates a reduction in the number of clinical placements for undergraduate students, but also impacts on sometimes the quality of the clinical placements. In response to some of the challenges that we were facing at my institution in New Zealand, I developed a simulation program which I introduced yesterday, and it was in the first year of the undergraduate nursing program, but in the second semester. And one of the objectives of this particular program, because it is different, the simulation here is slightly different to how a simulation would normally be done. But one of the main objectives was to allow the students themselves to have an opportunity to be the recipients of nursing care as well as the providers, and to see what that was like, as many of them had never been recipients of any sort of nursing care. So very basically with the program, they went through a 3-day rotation in the roles of the patient, the nurse and the observer. And at the end of each session, they had a structured debrief using Christina Dreyfus's DML tool, which was a structured debriefing tool. So this program was new, and the purpose of this research was to look at the quality and really to critique the way it had been structured to see if there were other ways of improving the outcomes for the students. And that's pretty much all it was to start with. So after gaining ethical consent from the Wintec's Ethics Committee, and also considering the ethical things, in consultation with Te Hoi Māori Ora at Wintec, just bearing in mind that New Zealand, although it is a multicultural society, we are a bicultural country, and our founding document is the Treaty of Waitangi. So in any sort of educational initiatives, we have to consider our obligations under the Treaty of Waitangi, and that includes ensuring that all our programs are appropriate for Māori in New Zealand. So we consulted with our kaiwhina, who is a Māori social worker in New Zealand, around the development of a simulated patient who was of Māori descent, and for her care. So it was a descriptive study design, and again using Kolb's experiential learning theory, which is very popular in the nursing profession due just to the experiential focus there. There was 158 self-selecting participants, and the study was done over 3 semesters. So there was, it was 3 semesters, and we did a questionnaire which was designed in 2 parts, essentially in 2 parts. The inclusion criteria was all self-selecting students who had completed the 4 days of the simulation program, and the tool was developed it was developed in relation to the program objectives. So we were looking to see whether or not we had, the students had the outcomes for them had been what we had projected in our objectives. In part 1, the students were asked to respond to 5 questions, or it was actually 5 statements, and in part 2 they were asked to evaluate the program, and that was by identifying things like the sessions that they enjoyed and those that provided the most learning for them. There was a Likert scale used for part 1 responses, and in part 2 the responses were categorised. For example, aspects of hands-on practice such as washing patients, oral care and bed making were put into the category of practice or hands-on. Core competencies in the categories were further identified and broader categories were developed and discussed. And looking at the results, oh my gosh, that shouldn't be there. Don't worry about that one. Okay, so looking at the results there, in part 1, 156 of the 158, or 98.3% of the students agreed or strongly agreed to the statement that the clinical practice simulation had assisted their learning. So it was quite a strong response there. In part 2, we asked them which sessions did you enjoy most, so wanting to know what was actually enjoyable in the program. And there was 148 of the 158 students who chose to respond in this question, and you can see that the huge slice of pie there goes to the practical session, and all sessions. Some of the students just enjoyed the whole program because it was an opportunity to do some hands-on practice and bring all the theory together. And you can see the other categories there, different aspects of the program. I asked them for future simulated practice in this module, I would, and this is where we were looking for their feedback on what could be done differently. And this was an unusual question. In fact, it was I'm not sure it was particularly functional, this question. It was answered in 2 ways, and this is the first way they responded. You can see that documentation prior to the program and more or longer sessions dominated that one. There was 110 responses out of 158 for that one. More discussion on scenarios, introduce equipment prior to program, theory before practice, notes for home, unknown patients. There's quite a number of categories there. We had lots and lots of suggestions. And I have to say that just before we go on, that at this stage in the program, the workshop would run in the morning and the clinical duty in the afternoon. So one group would have practice before theory and one would have theory before practice, and then they would hand over. So if you see there the theory before practice, they didn't appreciate that at all. I mean, they wanted the theory before practice, they didn't appreciate not having that. Now, some of them responded in a very personal way, which actually was quite interesting. They took this as a very personal response and said they would enjoy attending. More experience, no surprises, integrate knowledge, ask more questions, use time more effectively, prior learning, better documentation, self-preparation. And I had one that said they wouldn't go out the night before. So it was very much out on its own, that one. The next thing we asked them about was during the weekly sessions, I learned most about. So we wanted to know not what they enjoyed the most, but where they actually got the most learning. So 112 of the 158 responded to this. And you can see that the practical skills and documentation and charting were huge in this one. And the others one's very much of a muchness. Equipment, professional processes. When they're talking about professional processes, we're talking about the admission process, the discharge process, the collaborative meeting, the medication management program and those sorts of things. Favourite part of simulation. Okay, so this one again, hands-on practical. So 98 students responded to this out of the 158. And the hands-on practice, of course, was very popular. Patient experience, they enjoyed as well, and some of them just said everything And then there's those other ones: critical thinking, self-environment, safe environment, clinical tutors, realisation, love being a nurse, that was a good one, skill demonstration, professional teamwork and communication, documentation. So looking at all the responses, we developed some themes, and the hands-on skill acquisition was a huge theme, an overall theme. The student is patient, so the patient experience. The documentation and charting was huge. These students had not had an opportunity to really use they hadn't been out in practice, so they really hadn't had an opportunity to look at the clinical paperwork or actually use the clinical paperwork. So the workshop provided them the opportunity, and then they used the professional documentation, filling out their care plans and their admission, chart and all that sort of thing with their simulated patient. So it was quite a new thing for them to do in a context. The realism, that was quite, as you can see through there, that thread winds through. Critical thinking, clinical decision making, which strangely was very low in their list. Okay, so in terms of the hands-on skill acquisition, they talked about safe, supportive environment and peer learning, which was really quite huge. And you can see the comments there. I did really well looking after, and everyone else thought so too. They were asking me questions. So it's like these students had an opportunity to see the nurse and actually see, reflect on their own skills in the context of the patient care, and feeling like a real nurse. So being able to consider, for some they said it was the first time they'd really thought of themselves as a nurse, as a first year student. Student as patient, which gave them some insight into the patient experience. And as they said, I've never been a patient before, and I just didn't think that the bedpan would be so hard and horrible to sit on. Another said I had to act confused, and others laughed at me. So that's rude. I'd hate to be laughed at. So you can see that from these experiences, they created quite strong emotions that they then have carried forward into their practice. Documentation and charting. Well, 45% of the students said that they learned most about documentation and charting. And I think, as we saw in the study yesterday, that could be because that's the thing that they knew least about. But you see there, I'd like to have seen the observation and medication charts and assessment documents prior to starting. So that was a student who had the theory second. Teamwork and communication. I hated it to start with, and I thought it sucked that we couldn't work with our friends. We didn't even know each other, and I don't know what to do, but they ended up being really cool, and we worked together really well. I feel a bit better about working with people I don't know now. I purposely selected the students into the simulation groups based on a cultural mix. I purposely split people up and put them with students they didn't know, and that might sound a little bit mean, but the thing is, that's what happens in practice. You don't get to choose who you work with, and part of the value in doing this is that you could address those things in the debriefing. You could address those challenges that they may have had within the team, and that could all be talked about in the debriefing. So it was a good opportunity. Critical thinking, clinical decision making. As I said, we used the DML debriefing tool by Christina Dreyfus. No mention. Now this really surprised me, and I expected that the theme of critical thinking, clinical decision making, which was every single part of their simulation. They had to justify what we were doing. They had to provide a rationale. In debriefing, they had to go back over how they'd intervened and why they'd intervened and what evidence they had for that. And I was really surprised that this didn't come through. And I anecdotally asked several of the students about this, and they said, well, it's just what we do. It's just what we're doing. So they didn't see it as something separate. They saw it as part of the practice, that they would rationalise care and have an evidence base. So it was quite an interesting perspective. In terms of limitations, this study didn't identify the age or the gender or the ethnicity of the participants. The number of students with previous practice experience was also not identified, but may have impacted on student responses. The questionnaire for data collection, rather than a validated evaluation tool, was generated from the program objectives. It's quite interesting, the second one there, about the number of students with previous practice. When I did the study, follow-up study to this, where I looked at practice, I saw that it kind of validated this too, because I saw that the students, in the pre-test that I did following up this, students rated themselves really high for their knowledge of their clinical skills. So that was their practice, their clinical skills. So I think it would have been helpful to know how many had previously worked as nurse assistants or healthcare assistants, or that might have explained that a little bit more. So recommendations moving on, that the age, gender and ethnicity of participants be noted, because that would help with the analysis. That a validated tool be used in future, and that's a challenge because this sort of simulation doesn't generally happen, so it's quite hard to get a tool that would actually be, appropriate for this mode of simulation. That all students attend the workshop prior to practice, and I can tell you that the semester after this evaluation was done, I started the students the day before. They did an afternoon, so they came into their clinical duty with the theory under their belt. In the afternoon, students had their workshop in the morning. So from that time on, all of the students had the theory prior to practice. So, and this is based on this feedback. Also, learning be quantified, and of course I did that follow-up study that I went through yesterday. But overall, as a newly developed program in the Bachelor of Nursing to support the nurses' learning, the simulated practice program was well supported. 100% of students agreed that the program should continue in the future. So it was a good start for us. Thank you. Are there any questions? Yes?
What age range would you say that the students were? I mean, even though you didn't gather that data, what age range? And the second part of my question is,
A little group from 4 persons. We care about the health policy, and the neonatal care have a big importance for the pediatric mortality. So we start to look at where I am from. I am a medical doctor, I am a neonatologist. I came from a city, in a little city in the south of Brazil. So I let all the Brazilians here, and the city of Itajaí is a small city. We have 200,000 inhabitants. We have at least 3,000 live births per year. 2,000 and a half are in the public maternity. In Brazil, the health care is for everyone. So even if you are an immigrant and have your baby there, you want to take your baby at our public maternity. It's happening with the IT. The IT immigrants are there. We are a port town city. We have a human development index of 0.79. Is the third of the province, and we have 76% of the city with the coverage of the public health for home care. Is a family care and a strategy for the government of the city, and in Brazil that's improving. Our province, our DC from province, Florianopolis, has 100% of the strategic cover. So we are looking for that. I believe it's a good strategy for health. We have a lot of nurses working in our city. The nurses do the prenatal care and do child health care too. We have one appointment with the nurse, one appointment with the medical doctor, and we have the smallest team that will be at least one nurse, one medical doctor, and a community health work. We call them in Portuguese as agentes comunitários de saúde. So I don't want to talk then about agents, because they are community health work. They have to be from the city, from the neighborhood, and know about the people they are caring for. So where do we start? At 2013, we had a lot of deaths in our city. We did it until 52 deaths from child under the 1 year age. This was very big. We didn't have this before. And more than that, here is the absolute number. More than that, this number of deaths from child under 1 year was not together with the number of lives born. So we are looking for a curve that don't have a pattern. We care about that because you can say that 17.3 for 1,000 live births is too high. We have to go down, and we start thinking about public policy. So to establish that down and stay a better curve, stay down. So we see too that our research is not the results. We saw that what we get with research is not what we get with results. We are the second highest rate of child mortality from the province, one of the largest number of child deaths from the province. And the oscillatory curve demonstrate increase and decrease in mortality rate by chance. So not associated an efficient public health policy. This cannot be a surprise, okay? You have to do your investment, you have to have the results for a better care. So I have to show that. I always bring this picture. I believe some of you have seen it before. It was from Chicago's fairs, 1930s. In 1930s, the child born with 2,500 grams was let for the doctor and the nurses to take care. And you cannot do that again. You have to take care of our children at their homes. So I talk with all the working group, and we start to show them that if you are not important to take care of our children, maybe we won't go back. We cannot live in the past. So you have to take care of the children. And I was thinking, which are the pillars to educate healthcare? So I think in three important issues: surveillance, care, and support. You have to have three things like basics for the healthcare. Surveillance. For the World Health Organization, public health surveillance is the continuous systematic collection, analysis, and interpretation of health-related data needed for the planning, implementation, and evaluation of the public health practice. We have a systematic collection of data. A lot of manual work, We have to be more informatic for this, but it's another talk. But we are not efficient at analysis and interpretation when we see that collection. We are not anticipating the health care process. So if you are having if you are having so many deaths, why you can anticipating the healthcare process? Why you don't do better for this? Actually, what kind of care we want? We saw this here too. We saw this. So we saw about WHO technical consultant about newborn health indicators, every newborn action plan. So we thought, well, let's do it home visit based care, the mother care and the baby care. We cannot forget about the mother. He have to have a breastfeeding appointment, no more than 7 days to do the visit at home. Better if the community health worker don't go alone, have to be with the nurse or the community doctor or both of them. So we start working a lot for do this. And support, we have to support our teams. Sometimes we think in public health and our teams don't have nothing to do about it. So we must be prepared for the needs that we have and support them. Sometimes the public policy knows, get the things and don't know what to do, or don't debate the issue. For it's like this doesn't have it. Having there. If not discussed, is not there. We need to evaluate and think about the strategy often. You have to rethink in the strategy. If you are doing something that's not going with a good result, you have to do it again. You have to rethinking. We have to give conditions for the proper work of our teams. This stay in my mind, so you have to give that. And in every level for healthcare, we have to do a preventive care. You have to, if you have the chance in the advanced level to do some preventive care, you have to do it. So you have to put it on all in our care. And most. Where do we start? Evaluate, action, re-evaluate, and action again. You have to do this all time. You have to do this with our process. We began talk with the largest working group in the public health, the community health worker and the nurse. Most of the nurses are supervisors in our facilities in primary care. That's help a lot. Total about 300 people working in the primary care in Itajaí. We talk with all community medical doctors about the numbers of mortality. Too, for the people who are working in their facility, doing their appointments, sometimes they don't know what is the number of deaths from your city. You just go there, do your work, and go out. So we have to talk with them about the numbers, show them that's not a good number for what we got, or what we got from our research resource. So we need them to know that. So what care? We have to do more attentive care, not a therapeutic care. The therapeutic care is when your primary care is not going good. So we are worried about attentive care, more about the visit at home for the mother and the baby, and less about a medical appointment. We tried thinking about integrative care and more of it. A care with responsibility is like to care about the mother and the baby. You have to do more than just therapeutic care, okay? We can put the mother in the center, mother and the baby at the center, look for the breastfeeding, desnutrition, jaundice in the screening test. You have to do this until the 7 days of life. We know that we don't have good numbers for breastfeeding in all world. When you look for, what to say, when you look for the very brief profile from the mothers in 2013, we don't found a social determinant for the number of neonatal deaths. So I bring you just a brief from our profile. We thought at first, oh, maybe the mother has too many children. Maybe the mother doesn't study the necessary study. Maybe it was some kind of infection, but there is not. The mother age, the average mother age was 25. Is a fertile woman. The number of children for this mother was 1.2. There is even two kids for her. So we are very worried about. We need to measure and evaluate the expected results. We try to anticipate them. So we think in a care movement, okay? How in what point we gonna work? We have to work in every point, every time. We don't have time to choose one point just for a public policy. So we start to take care of the prenatal care, intrapartum care, and home care, and these three together foresee what we got. So breastfeeding empowerment, diabetes, maternal nutrition, maternal hypertension, urinary tract infection, and in Brazil at the south, where is a port city, maybe happens in others towns like this, we got syphilis, okay? Intrapartum care, we have attendant skilled health staff. Almost all our care, our attendant intrapartum care are for skilled health staff. We have nurses too, for obstetrician nurse that do a very good work. The golden hour we are begin to talking about. The father together or someone from the family in the intrapartum scene is a very good work. Newborn measures and physical examination after 1 hour. Okay. And the home care even start at the hospital. The nurse talk with the mother and is already visit agenda, visit day for the home. So the mother become very precious. She sees that somebody is worrying about her and the children. No more than 7 days. Look for some risk factors. The child logbook is where you give your appointments, a nurse or medical visit. So we think about care movement in the city. We not have yet the breastfeeding week at our city. So in the last year, 2015, now this year, we did a walk for the city. It was the first walk for breastfeeding, but some of culture problem. We have 200,000 people. We have 100, just 100, not 1,000, huh? Just 100 people for that walk, okay? The workers of the health secretary didn't go if they don't have a day for without work after. So we are care a lot of that too. A municipal law, we get it for support breastfeeding action. So this action is going to be next year, next year, next year. For this is going to be a public policy, and we are good for that. And for the 2013 for 2014, we did from 11 here for 2 deaths here. This is the neonatal period from 7 to 28 days of life. So we got, for the total, we got 20 less deaths of children under 1 year. That was a good work. I believe that we have to continue, and you are caring very much about. So maybe we can go down again and see the numbers to be below 12. The Brazil, the whole nation have the number about 14. We are at 10. I believe that what we got, the number of people that are working, we are able to do under 10. So I'm talking that very much. So we got more lives, more live births, and less deaths. That's so important. We have almost 20 deaths under. So we must continue. We believe that the set of our actions, and not just one or the other, has been essential for improved results. We need to get a better result for the neonatal early deaths. I didn't talk so much about the natal care, the neonatal early deaths, because 18 of them occur less than 5 days of life. So we have to start this work at the prenatal care. It's going to be a lot of work. We have to improve a lot of our prenatal assistance. We must continue all the actions and have more patterns for help. You have to invest in education for all. The mother have to know what rights she got. She have to ask for the politicians to invest in her health. And we need to have more education for people, for they ask more quality for health. And so maybe we can get out from the cycle that this loss of education do it with our people, the people we care about. So we are 4 people working at the city. This is the city hall. These 3 are nurses. I'm here by myself, so they couldn't came here. The city don't give the money that for they come for here. They are working now, and this is my family. So thank you for everyone. Questions? Yes. Okay. Thank you very much. Thank you very much. I believe.
I think there's a, Lisa? Oh, there.
Yes. Yeah.
Sciences, and currently I'm working as a Deputy Chief Nursing Superintendent in Pakistan Institute of Medical Science in Islamabad, Pakistan. It's the capital city of Pakistan. As you know, in a nutshell, the Pakistan is dense populated, the country containing the 192 million population and consists of 4 provinces. And I personally belong to the provinces of Sindh. The Sindh is known as the land of Sufis, the spiritual leaders in the sense. And then rest of the provinces like Punjab and Khyber Pakhtunkhwa and Balochistan, these are remaining 3 provinces and in the Pakistan. And I'm working in the capital city of Pakistan in Islamabad as a Deputy Chief Nurse. Regarding my MSc, and I have postmaster's diploma in hospital administration and a diploma in education planning and management in respect of MSc nursing. Today I have the opportunity to talk about the barriers to participation in non-formal continuing nursing education programs amongst the hospital nurses in the Pakistan Institute of Medical Science in Pakistan. As an introduction, the technological advancement stresses the need for CNE. As you know, there is an expansion and the introduction of the technology, and we are living in the techno-based world, and already we are talking from yesterday, the economy. The world is shifted to the economy-based, and the technology is basically the NVN. And then the concept of continuing education is not new, it's old. And then the continuing medical education and continuing nursing education is worldwide recognized and accepted. And then the practice became obsolete after 5 to 10 years of the experiences. And as I can say, the basic nursing study is not the end point after the basic study, because there need to be the refresher of the courses. Because once we are stagnant in one of the practices, our practices are as a traditional practices. We are not talk about this, the practices has been reformed and refreshed. Therefore, we need to refresh our practices, because into 5 to 10 years of our employed nurses are employed in the hospital, the practices become obsolete. There's need to be develop refresher programs. And then nurses keep abreast with current medical knowledge and technology exposure. That's why the nurses, the dire need of time that nurses should develop the course as designed to refresh their practices in real clinical scenario. Study suggested that the regular training programs will be offered to all employed nurses. They must be organized in such a way that they can refresh their practices. And some studies suggested that in 1 year, 70,000 of the client, we can say, disability and morbidity is increased due to ineffective practices of the nurses and the skill mix workers. It is because of the non-documented of the refresher courses. That's why the nurses should need to develop the opportunity of the refresher program in their clinical settings. When this program is already developed, the increased level of continuity care we can achieve the goal of continuity care, and then we can reduce the stay of client in our hospital and decrease the cost of expenditure. Because when one patient is admitted in the hospital, we should look at the factors, the economy factor, because even patient come from the underprivileged area, there should be, we should look at the cost as basically. That's why my objective of the study was to investigate the most influential predicting barriers that impeding nurses' participation in continuing education program, particularly non-formal, and suggest the strategies to increase nurses' participation in that programs. The literature suggested that the continuing nursing education program is worldwide accepted by American Nursing Association, and the continuing nursing education program by definition is a planned and organized trainings or course of study after a basic nursing course of study. It is the course that provides credentials or the certificates of participation. Why we should that? Because of our aim is to ensure continuous quality care to provide in the patients regarding the clinical or hospital settings. And when you talk about, there are three types of, we can say, the continuing nursing education programs that I personally have the extensive literature and find out some the educational Department of Education. So I have found the three types of continuing nursing education is the formal CNE programs, which is based on the credentials, degrees, diplomas, like BACN, post-RN, BACN, MACN, and PhDs. Non-formal CNE program, which is, I personally talk about the non-formal CNE program, which is based on my research. It's two types, hospital-based intramural programs and the extramural programs, including workshop, short courses, and symposium, the conferences that we have here attended, and the orientation program in the hospitals or even the school or college sites. And then the informal CNE program, continuing the self-directed learning that we provide the employed nurses at the Center of Learning Resource Center. They must browse, they work on the research, they must develop the hypothesis for any clinical research. And this is the informal CNE programs. That should be a platform of, we have provided the platform in our hospital Learning Resource Center. The employed nurses should work on their own research projects. The methodology study design, this was the descriptive cross-sectional study, and the study was conducted at the University of Health Sciences, Lahore in Pakistan, and the study population, the all employed nurses. This is the inclusion criteria. The exclusion criteria is the student nurses, and the skill mix, lady health worker, midwives are the exclusion criteria. The sampling techniques are convenient sampling, and the data collection method are modified barriers to participation questionnaire. It was modified from deterrent to participation scale, which was formerly permission was sought from the Scannell and Darkinwin in 1984. And data were analyzed on SP variant 17. And the results, the administration barrier found was 67%. The nurses reported that the administration barrier is a more influential barrier in the study. And the work-related barriers, 55% nurses reported the work-related barriers due to the undue assignments, overload of the hospital patients, and etc. And the financial barriers, 36% of nurses reported that there is a financial resource. We have any financial funding to afford the courses in non-formal particularly. And the family barrier 26% and personal barriers in 30%. Regarding mean standard deviation, the personal barrier, because when the tool was developed, barrier to participation scale, interpretation, higher the mean score, it means the lower the barrier is measured, and the lower the mean score, higher the barrier was measured. Because of the tool was started from the strongly agree, some extent agree, and disagree, and strongly disagree. And it is start from 1 into 5, but it was started from the 5 into 1. That's why the interpretation is the higher the mean score, the lower the barrier is measured, and the lower the mean score, higher the barrier is measured. And conclude that most prevalent barrier is the administrative barrier, 2.9, and work-related barrier is 2.53. And the predictive financial barrier, at some or now no barrier exists, is the family barrier, and no barrier is personal barrier. It was in statistically. And discussion, in my personal experiences, once I distributed the questionnaire to nurses, they have multiple arguments regarding 3 barriers were found as administrative as the most prevalent, work-related as the more predictive, and the financial as the predictive barriers. Majority of nurses' favoritism of administration said, oh yes, the administration send their favorite person for trainings or course repeatedly, that whom they like or having any interest. This is a common perception. They still not fill the questionnaire. Once they receive the questionnaire, they remarks, they argue, oh, the administration is the favoritism. They send their own leave, the favorite person, the trainings and whatsoever. When we apply for training or any course, our documents, the papers knowingly misplaced, and at the end, new person go for training because administration nominated names of their own favorite persons. These are basically the insight of the nurses that they are working the clinical side. I recorded these as a statement period, they fill the questionnaires. The administration doesn't circulate proper information of the course or workshops and do not circulate information at the meantime or circulate in days where closing date is near to finish and the nick of time some favorite person nominated for the training. They don't know who person is going for the training. So the administration, they impose or we can say nominate their, in one study I found that the same person is nominated on the further trainings. So that's why the nurses, we can say arguments that we do not apply in refresher trainings because we don't nominate in further trainings. That's why we have no interest. Actually, our senior nurses do not want to send nurses for further trainings. This is again, one of the nurse said, our workshop, because they have threat that in future they may be promoted a higher post or we may be replaced. And maybe all the senior nurses and have no knowledge about CNE programs. Yes, regarding work-related behaviors, can't go to attend session because of busy wards. These are the statements regarding this. Some views unable to attend because of shift-wise duty, night and evening, that's why. And can't attend because of the training session, no convenience are available. There are transport problems, have issues. Regarding financial barrier, few nurses showed that why we participate because no salary increase, no any incentive is awarded. This is the remarks. And many of them comment whatever the expense used on the trainings, we will bear on self and participate in lecture any course because they are on self-funding program. That's why they're not likely to attend the sessions. Some recommendations, I put the recommendation in the local level and the provincial level. And they should develop the CNE cell in the hospital base that I have developed in my hospital, and the provincial director nursing should develop their own department of continuing nursing education. They boost their non-formal programs. And at ministry level, at the federal level, I have put the remarks into the Ministry of Health, nursing advisor, to formulate the policy and formulate policy of non-formal CNE programs, and all the conferences, workshops, and these symposium courses should be accredited by the CNE points. That's why in line ministry with the Pakistan Nursing Council should be involved in relation with these recommendations. And these are some strategies that should follow, that once you are being a manager, you should develop the interest and explore the program, formal CNE program, non-formal CNE program, and informal. And explore types of programs you are launching in your hospital, and the sequence of these steps should follow in that sense. The conclusion, education and practice cannot live in isolation, but needs to develop sustainable refresher courses, a program by means of continuing nursing education activities. If you want to improve your effective and obsolete practices into techno-based medical knowledge and skills, you must revolve around CNE programs opportunities. Wisdom is not a product of schooling, but lifelong attempt to acquire it. It's a thought. Some of the limitations, financial constraint, definitely I have research conducted by my own, and time constraint, we have insufficient time, and distance constraint, because I have data collection over 2 provinces, Sindh and Punjab. There's a distance issue. This was a cross-sectional study, one angle of barriers discoursed, and sample size was not larger at extent. Thank you. I'm thankful to OMICS Group that provided us the opportunity to here to visit and to share with you and the expertise of a nursing professional. Thank you very much.
I'm a doctoral student of Yonsei University College of Nursing. I'd like to talk about factors of participation in prenatal education among nulliparous women in South Korea. The contents are as follows. I want to start by giving you some background information about this study. Since the 1980s, the total fertility rate has continuously and rapidly dropped in South Korea. South Korea has recorded a very low total fertility rate of 1.18 in 2013, and the lowest level compared to the OECD average. Higher marriage age leads to increasing pregnancy of advanced maternal age and pregnancy complications, preterm births, and congenital malformation are increasing. As a result, the number of people is declining steadily. For this reason, the importance of better foundations for the lifelong health of the pregnant women are emerging. Pregnant women need prenatal care to improve maternal fetal health during pregnancy. Especially nulliparous women are strongly recommended to participate in prenatal education because pregnancy and delivery is the first experience. According to previous studies, pregnant women who participated in a prenatal education were higher get prenatal care compared to pregnant women who didn't participate. Regular prenatal care can reduce the perinatal complications in pregnant women and newborns. Therefore, this study aimed to identify the contents of prenatal education conducted to examine the level of participation in prenatal education and to determine influencing factors of participation in prenatal education. Let me explain methods of this study. This cross-sectional exploratory study recruited 134 nulliparous women living in the metropolitan area in South Korea. Gestational age were 32 weeks or more. See a healthcare provider at a hospital or OB/GYN clinic, and no physical and psychological disorder. Survey data were collected by face-to-face interviews using structured questionnaires. This slide shows the measurements of this study used. Experience of prenatal education measures by degree of participated in prenatal education. Knowledge measured by knowledge related to delivery, postpartum care, newborn care. Self-care for delivery, postpartum care, self-care efficacy, parenting confidence indicate about attitude. Data analysis was performed using the SPSS and data. Descriptive statistic and multiple linear regression was used. Let's move on the result part. This slide displays detailed descriptions of characteristics of subject. Lots of subjects were from 31 to 35 years old. The average age was 32 years old. Education level was more than college graduate. Housewives were 49%. Planned pregnancy were approximately 2/3. Participations of prenatal education rate were 54%. Subject who did not participate in prenatal education is the most common response by 36%, difficult to meet the time due to job. Total number of prenatal education contents were 35 items. I reviewed the homepage of Ministry of Health and Welfare, 5 community health care centers, 9 medical centers, and then deducted 35 items. Items for prenatal care and childbirth were 15. Self-care of puerperium were 10, and newborn care were 10. Contents validity conducted by face validity. The items for prenatal care and childbirth showed that a level of high participation was overview of prenatal care, the importance of breastfeeding and preparation, physical and emotional changes during pregnancy, and understanding the stage of labor. The items for self-care of puerperium displayed that level of high participation was preparing for breastfeeding and meaning and importance of puerperium. The items for newborn care showed that level of high participation was breastfeeding and belching, management of umbilical bathing, and growth and development. A multiple linear regression shows that women using books and healthcare provider as a first information source were more likely to participate in prenatal education compared to those preferring internet website or family. Knowledge about delivery, postpartum self-care, newborn care among nulliparous women were predicted by levels of participation in prenatal education, occupation, and income. An attitude about self-efficacy for delivery, postpartum care, and parenting confidence were predicted by age and income. To conclude, individual characteristics and participate in prenatal education are critical for the success of preparing nulliparous women as a new mother. The findings of this study suggest that nurses and physicians should emphasize the importance of prenatal education and should establish strategies to improve participation in prenatal education, especially for working pregnant women. Thank you. Thank you very much. Any questions?
go. So basically, I'm going to speak to you about key expert training components, the logistical and operational considerations for doing this training in an emergency room. And thanks to Joe, we have a vignette that we can share, and I'll go over some of the results. So who we are is I was the project coordinator on the grant. We're just sending in the final report to the grant reviewer bodies, and Anne, who was the actual project director. The rest of the project team is listed on our slides, and we want to thank the Nurse Education Practice and Retention Program.
Having this workshop to present diverse aspects of health promotion and preventing disease in the context of rural South Africa. So my topic is improving the tuberculosis control using the directly observed treatment program in Limpopo Province, South Africa. Here are the presenters. Diane Mabunda is my PhD student who qualified, and this is part of the objective on her study. The introduction, we are all aware that tuberculosis is a major problem, health problem globally and in South Africa. It's the problem number one, has overtaken HIV and AIDS. In 2012, 8.5 million people fell ill with TB globally. There were 1.3 million TB deaths in 2012 globally. And then that number of people had new drug resistance, which is called DR, TB cases in 2012 globally. And South Africa remains one of the 22 high-burden countries. And currently we are I think we're number 5 now with TB burden after the other countries. And South Africa is the highest TB incidence rate globally, as it's indicated there. This is WHO report of 2013. TB ranks as the second leading cause of death in South Africa after HIV/AIDS virus. This is obtained from Statistics South Africa 2013. So here I just want to show you where this is South Africa, and when we look there, I'm sorry, it won't show. Let me try. This is my university, University of Venda. That's where we are located. We're a rural-based university located, okay, thank you, in this Vembe district of Limpopo Province. Thank you. We are centrally placed in the South African region in close proximity to Botswana, Mozambique, and Zimbabwe. That's where we are. Okay, you see, and then you see Botswana, and Namibia, Zimbabwe, and Mozambique. That's where we are. And then Limpopo Province is one of the provinces in South Africa. This is the map of the province, and we are coming from the Vembe region, next to the border of Zimbabwe. Directly observed treatment. Short course DOTS is the cornerstone of TB control in developing countries. DOT is a program where patients are observed taking treatment by a trained healthcare worker or a volunteer. The main aim of DOT is to improve treatment adherence and completion of treatment. Both facility-based and community-based DOT is employed in Limpopo. A variety of DOT supporters include healthcare workers, community home-based carers, friends, relatives, teachers, and employers. And DOT supporters are utilized to assist with treatment adherence for TB patients. They have a major role to play in TB control. They are, however, faced with challenges at times. Here is a slide showing the burden of TB among selected high-burden countries. And then look at us at the bottom. That's where we are in terms of TB burden, high-burden countries. The purpose of the study was to examine the roles, responsibilities, and challenges faced by DOT supporters as they support and supervise TB patients with medication. The methodology employed, the study conducted in 2 districts, that is Capricorn and Mopani. A qualitative design was employed. Focus group discussions were conducted with community health workers. That is not community health workers, health care workers, including the provincial management, district, sub-district coordinators, and dot supporters in Mopani and Capricorn district of Limpopo. Individual interviews were conducted with patients. Semi-structured interviews guide used to collect data. All participants were asked to describe verbally the challenges experienced by DOT supporters in the implementation of DOT program. The focus groups discussion were audio recorded, transcribed, verbatim, and later analyzed. I'll come to the findings. Motivation for DOT supporters. What motivated you to be a DOT supporter? These are the responses. Assisting communities formed the primary motivation. Previous experience with TB, caring attitude developed, relative with TB, having seen DOT supporters at work, unemployed acted as a driving force, witnessed some DOT supporters employed as lay counselors. What do you enjoy about the DOT program? The teaching role gives meaningful contribution to TB, good services provision with positive results, personal feelings of achievement, community appreciation. What are your responsibilities towards your patients and healthcare facilities? Tracing of defaulters, follow-up of patients. Is their pride? Referral of suspects to clinic for screening, side effects and social assistance, involvement of family members in the care of the patient for support and encouragement, actual DOT supervision of treatment intake by patients, extended act of caring, preparing food for patients, providing meals for patients. However, there are challenges experienced by these DOT supporters, treatment interrupters and defaulters, e.g. DOT supporters worried about the treatment, defaulters, especially male patients who abuse alcohol, high pill burden, stigma, use of traditional medication is a problem in our rural context, infection from TB and MDR TB, e.g. safety during sputum collection is a challenge to them, working as volunteers without stipend, registration process as NGOs frustrating, need for continuous in-service and updates, meetings with clinic staff, which is positive to them, effects of social grants that acts as a deterrent to treatment completion. Here, once a social grant is granted, it's withdrawn from patient, the patient stops treatment, and this poses a challenge. Suggestions for improvement. What do you suggest should be done to improve the program? Remuneration of stipend and incentives for DOT supporters, it was found essential. Institutionalization of TB patients, they are no longer institutionalized, they are carried at home. And then perseverance in spite of challenges, commitments to the patients, employment prospects. Recommendation. Remuneration also came very, very strong. Those supporters prioritized when job opportunities arise because they are not included in the professional structure of the government. Assistance to register DOT groups as NGOs in order to access funding, regular meetings by healthcare workers with DOT supporters, conduct DOT acknowledgement days, healthcare workers to treat DOT supporters with respect. Summary, groups of provincial district and sub-district coordinators also voiced out similar findings as for DOT supporters. DOT supporters are committed to rendering the service to their communities despite the challenges experienced. Department greatly acknowledged the contribution by DOT supporters. So these are just TB data case findings, Lipompo versus the national. The blue is our national data, and Lipompo province, that's where we are. So it shows how the case finding is captured and reflected statistically. TB data of case findings, again you see the linear Lipompo. That's how we fare. We were up between 2008 and 2011 and gradually now going down. TB and HIV burden in South Africa. This is quite interesting now. We see TB cases overtaking HIV prevalence. It's steeply rising, the TB infections. Acknowledgements, we acknowledge the South Africa and Netherlands programs that provided funding, research promoters from South Africa and the Netherlands, and those people, Department of Health and fellow doctoral master students in the project. We can stop TB. We beat TB. Thank you.
so that everyone can hear our speaker. I'm going to introduce Sonto Maputele. Parents' perception regarding sex education of their adolescent children, perspectives from a community in Mopani District, South Africa. Thank you.
Okay, thank you, Chairperson. I'm going to present the study on perceptions, parents' perceptions regarding sex education of their adolescent children, their perspectives. So, as the previous speaker mentioned that we are from Limpopo, I think she showed us where we are. We're both from University of Venda, but remember that we are from the very, very rural area. And she has already alluded that we have a challenge of we are too traditional in that context. So in this case, parents play parenting role. They play a major role in sexual socialization and education of the adolescents' children. But now in this case, where we are staying, we're faced with the issue of culture, where the culture is mostly, it's a taboo to discuss sexual issues or sexual matters with your own child in the family. So in such setting, you find that some of the adolescents will learn get wrong information from the peers outside, especially if they didn't get the accurate information from the parents. So these were some of the problems that we are having. And then where we find now that some of the researchers like Maluleka concurred that yes, in the context of our area, discussing sex in the public is not an easily topic that can be discussed. It's an area that most of our children are discussing with their peers. However, this is it was found to be very, very harmful because the teenagers were not getting accurate information. So in the study by Libisi also, they found that parents were very uncomfortable to talk about sex with their children, sex and sexuality with their children. And at times you find that parents will make indirect speeches with their kids. Then this may even give a distorted information because now they are getting wrong messages regarding the core matter of sexual education. Teachers too were also found to be reported as having discomfort in discussing direct issues of sexuality, because now even if they were talking about sexuality issues, at times they were not as direct for the adolescents so that they get accurate information. Then they will end up experimenting with their peers outside. And it gave problem because now when they learn to experiment outside, as our previous speaker mentioned, that we have a high prevalence of HIV and AIDS, we have high prevalence of teenage pregnancy and even of STIs. And amongst this age group also, it's an alarming. So the study was conducted in one village, 3 villages within the Mopani district, and these were the villages. It was Masema, Niki, those were the village, but that's where, because it was contextual, we're looking at specifically that area, because why that study was conducted, there was a high incidence of pregnancy rate. For example, in 2 secondary schools, they found that in 2010 and 2011 respectively, there was high incidence and prevalence of teenagers who became pregnant, and in the other school they were 27. And also there was a report that some of the kids from that same school were charged with engaging consensual sexual penetration, and they were under the age of 16. So now that raised a concern. What is it? We know that yes, at school there's a component of a life skill where it includes sex education, but what is it that those kids are getting from home? Hence the study, because this was also a challenge that there were high incidents of HIV and AIDS. Most of them were dropping out of schools, and at times they were performing the abortions that were not legal. The purpose of the study then was to explore the perception of parents on giving sex education on their own children. A qualitative exploratory contextual study was research design. Ethical approval was obtained from all relevant stakeholders, and then population consisted of parents of pregnant adolescents who delivered within a year, and those who were residing on those villages that were mentioned. That the sampling was non-probability convenience, because now we managed to get only 10 participants. It was a qualitative study. Data was collected through unstructured in-depth interview. One central question was conducted in a local language, and followed by probing was raised. The question was, how is it feel like to provide sex education to your child at home? Probing was done until data saturation was reached. Data collection was done through open coding. Similar topics were compiled until we came up with one theme and 2 sub-themes. Trustworthiness was ensured using the 4 criteria by Guba. So with the results, 2 themes came up. The first one was cultural belief system was cited as a barrier to sex education at home, and sex-related communication was used as a strategy to prevent HIV and AIDS. Specifically, they were worried about specifically HIV and AIDS more than equipping their kids at home. So according to this, still the cultural issues came up, because now culture was found to guide and bounce life practices. And the findings highlighted the influence of culture that it's having on the perceptions of the parents. So there was a belief that adolescents receive sex education, because this is a cultural practice again, at their initiation school. However, the content that was given there, again, some of the parents were not, the content that was given there, it might not be as accurate as what these kids were needing. One of the parents indicated that even myself, I'd learned about sex at the initiation school. Again, this was also affirmed by one author who indicated that yes, at the initiation school, yes, they are warning kids about sex at an early stage. However, we find that some of the girls are taught about sexual intercourse. That was giving a mixed messages, because now on the other hand, that was not accurate, but they were taught about that. So that was another thing that made us to suspect that maybe the information that is given might not be accurate. And again, culturally, as a parent, to talk to your child about sex was regarded as a taboo. Hence, most of the parents were finding it difficult to discuss sex with their own kids. Hence, you find that culturally, one family member may be delegated to talk about an adolescent about sexual issues. However, this person may be an elderly aunt, but unfortunately, this person is not a person who may stay with that adolescent continuously. Hence, this now, some of the code was, I delegate my relative to educate my adolescent about sex. Someone was saying, I'm afraid that if I talk about this with them and I'm with their father, they will say maybe I'm telling them what we were doing. But now this was supported when it's indicated that yes, parents become very, very uncomfortable to talk about sex and sexuality with their children. And hence they will make these indirect speeches, as I've mentioned earlier, and then this can be misinterpreted. And again, it was found that the aunt may be staying, the person who's delegated, as I've indicated, may be staying far from the adolescent. Then that continuity of assisting the adolescent may be interrupted. Hence, the adolescent may get information from the friends. The second one, as I've indicated, more information will just focus on prevention on HIV and AIDS rather than on specifically the sexual issues. Parents will educate. Yes, they were mentioning that as soon as my child start menstruation, I'll talk about issues of sex, focusing on STI, prevention of pregnancy, and mostly we're emphasizing that yes, church is doing that, because at church they are teaching our kids about issues of sex and prevention of pregnancy and the like. Hence, one parent was saying, I educate him about danger of engaging in sexual activity. Someone was saying, yes, I encourage my child to attend church because at church they do group counseling. And one will say, yeah, I advise my child to carry a condom. And while contrary, because they were not that specific, we'll just say, don't play with boys, you'll become pregnant at an early age. Now they didn't know that why shouldn't I play with boys? So in conclusion, it was concluded that yes, cultural beliefs and attitude dominate how and they also influence how parents relate to their adolescents. Again, this barrier may affect sex education because of cultural factors of lack of information, that accurate information was not given to the adolescents at their stage. So the implication for practice is that to facilitate parent education session where maybe parents and all stakeholders should collaborate so that the age-specific adolescent sex education could be given, and to develop contextual content maybe for facilitators for those initiation schools, so that even, because that's another area where you can get these kids and then they can get accurate information from the facilitators, and to strengthen the implementation of culture sensitive, youth friendly services. We need to embrace and understand that they are there. Thank you.
me just get my drink.
Afternoon. Let's get started. We have Anastasia Zute, am I right?
Yeah.
Okay.
That's my name.
From University of Wolverhampton.
No, Wolverhampton.
Wolverhampton.
Yeah.
UK. She will be reading a paper on. I will praise myself how Nigerian women negotiate family dynamics in the course of malaria prevention. Thank you. Over to you.
Thank you so much. I want to use this opportunity to thank the OMICS Group for this amazing opportunity to present part of my research work in this conference. Thank you so much. I may be anxious because of, I'm supposed to be in my bed now sleeping. And it's surprising to see yourself, staying awake all day, 24 hours. Because last night I had like 2 hours sleep because I'm supposed to be, doing my activities and, I need to kind of adjust a bit. Yeah, my presentation is on malaria. What can we learn from experience? Who am I? The important question here is not just who am I, but where am I positioned in my research? As you can see, I am Anastasia. I'm a wife, a mother, a midwife, a Nigerian woman. All these things I have in common with my participants. I'm also a doctoral candidate. My presentation today has a title, I Will Praise Myself. This is one of my participants. This is one of my participants, the word she used. But the most important thing in my presentation today is how Nigerian women negotiate family dynamics in the course of malaria prevention. But before we go to this, I want to show us the context. Malaria. As you can see, malaria is a big problem in sub-Saharan Africa. Pregnant women and children under the age of 5 are at risk. 25 million pregnancies are at risk. Thousands, 100,000, 200,000 deaths are recorded yearly. In Nigeria, where this research was conducted, malaria accounts for 60% outpatient visits, 30% childhood deaths, 11% maternal deaths. All these things are the cause of malaria, and that's why we need to do this research. However, Albert Einstein is one of the fathers of science. He said, not everything that can be counted counts, which means it's not all about numbers and figures. And not everything that counts can be counted. You can learn from experience because experience cannot be counted. The previous slide showed us about figures. And figures, we can learn something from figures as well as experience. And I will be talking about experience, what we can learn from experience. In fact, Nigerian researchers, they've noticed that malaria research is dominated by quantitative research, and they are calling for more social participatory research so that we can hear what people are saying. And of course, this is where the research is conducted. You can see the map of Nigeria in case if you don't know, if you have not seen it. And you can see the local area where this research was conducted. The focus of my research is exploring malaria prevention using insecticide-treated nets through the experience of mothers in rural Nigeria. Like I said before, I am a wife, a mother, a Nigerian woman. And my family, they live in Nigeria. My children are in Nigeria as well. So I'm part of this research. I'm not just an outsider talking. Research approach. As you can see, the research approach is not quantitative research. The approach we use is what we call hermeneutic phenomenology. Essentially, this is a discipline that focuses on the subjective experience of individuals and groups. It is an attempt to unveil the world as experienced by the subject through their life world stories. Hermeneutic approach is of the belief that realities are multiple. People experience realities in different ways, depending on where you're coming from. And the knowledge is that powerful knowledge, legitimate knowledge, useful knowledge are found in experience and shared subjectivities. You can learn from experience, and we can learn from figures and numbers, as I showed the previous slide. You can tell from it. So what did I do, first of all? Working through local gatekeepers. I used a combination of purposive and snowball sampling to identify informed women, not all those that have had experience of malaria, not just people who are hypothesizing about it. And a range of age, education, marital, social economic status, and knowledge were also the criteria for this. And this is just to get a rich data. 20 pregnant women and mothers and 19 health workers participated in semi-structured individual interviews, followed by focus group discussion. What did I find out? On my first field trip, as you can see, you may not understand what this is all about, but this is a clip of poster I presented last year at second International Nursing and Healthcare. That was last year, November. I presented this poster, but this is just a clip of it. And these are the developing themes that came out after my first analysis. Sharing good practice among mothers, encouraging health workers as role model in malaria prevention, fostering effective team working in the sharing of nets, taking it to the areas where they are most needed. So after, I now ask myself, what else can participant stories tell us to give further insight to inform good practice? Because these women, they told me a lot of stories. You know, when you're conducting an interview, so many things, they will say a lot of things. But it was during analysis that I started noticing so many things, so many gaps, you know. And again, I asked myself, what is the impact of the project on my own story? Like I said, I am a Nigerian woman. I said it, I live in Nigeria, although I'm studying in the UK, but that has not made me any different, okay? So, I noticed that there were so many gaps in my first interpretation So I decided I have to go back to these women in what I called validation field trip. It's the most vulnerable because this is where this topic just emanated from. Validation I use here is not just to go and ask these women, how have I done well? No, it's just to get their critical feedback on my early interpretation. And not only that, to go beyond themes, seeking a more nuanced understanding, deeper understanding, subtle understanding of how the women make sense out of their situation in relation to malaria. And in the process, during the field work, I noticed that these women, they started talking. The things they could not say before, they started telling me. Probably because I came back, I don't know. But they started talking. And I was able to see that these women are facing a lot of problems, a lot of challenges in the process of protecting themselves and their children. And it has affected their capacity, their ability, their effort in order to, live a more peaceful life in their family. So working with these participant stories, like I said, my name is Anastasia. So what I did when I went back to these women was to, ask them further questions, because I noticed that some of them were using the net. Some said, I don't use the net. Then to further explain that, I said, could you explain why some homes use the net, why others are not using net? Grace. This name is not Grace, okay? Grace, she said, and is one of the health workers. She said, depending on the husband's choice, if husband disapproves it, that's it. And if not, there will be conflict. So in order to explore the conflict, I said, apart from net, could someone talk about any issue at home that conflict exists between you and your husband and how you resolved it? And this led to recount an interesting story, NECA story. Please, can you just read it? I know some of us will be wondering, what has this story got to do with malaria or the use of nets? I'll come to this, okay? Okay. Before then, an American author by name Otto Frank. His life work has been on stories of people suffering from one disease or the other, and the health care workers. And he suggests that as much as we work on stories, by analyzing them, analyzing data, stories do their work on us. For example, in terms of their capacity to bring people together and to keep them apart, story can bring people together and at the same time keep them apart. He also explains that stories work. He also explains the work that stories do, and he has 4 of these categories. He said, stories deal with troublesome problems, offer different possibility for action identity, open up moral complexity, open a portal to other stories. I'm not going to dwell on this, but I'll just say a little bit. Deals with a troublesome problem. Like if you look at, if you reflect on NECA's story, the problem NECA had was problem of sagging bed. She had discomfort and pain sleeping on this bed, but the husband doesn't see it as anything because the problem is not affecting him. So this NECA story, what we did was to, position NECA story in line with the transcribed data. We also place the people's narrative under these categories. And as you can see, one of them said, depending on husband's choice, if husband disapproves it, that's it. If not, there will be conflict. And so another person said, it is only when that problem is directly affects the man that he will be interested in it. And that's exactly what's happening in malaria prevention. If husband does not like the use of insecticide-treated nets, there's no way the family will sleep under it. But if he likes it, yeah, he'll give the money. But NECA was able to solve her problem because she has the money. She got the capital. She's empowered. But other people, they have other things they do because they don't have the money. Even NECA, she played her own part by negotiating with the husband, you know, trying to discuss it. Hello, dear. There's need to change this bed. Please, can we change this bed? NECA would have gone to the market because she has the money. She would have gone to the market to buy this bed, but she never did it because she still respects the husband, and that is typical of African countries. We respect our husbands, sorry, not just what we do, just to be submissive. I'm not trying to do any play up here. But look at what happened. She was able to sort out this problem because she's working, she has money. So telling the husband that she wants to buy is just kind of respect. And others said, I think using the strategy that works for you and your husband is the best. For me, I use soft and bedroom voice, and that has been working for me. Nagging does not work for me. He will just do whatever I ask him to do when he sees me crying. That may be, some of us here may be using this. I don't know. Open up moral complaints. I'm just rushing it. Yeah, I'm just rushing it. What we are saying is a kind of subjugation. This is explaining why women are being subjugated. If you notice what NECA's story is all about, is just denoting subjugation of women, especially in the African continent. But NECA was able to sort out herself because she is empowered. And that leads to the last one, which says, it opens portal to other stories. And as you can see, it leads to empowerment of people. And and it opens portal to other stories that some of them even mentioned stories of other women who are already empowered, like Kobe, you know, Patient Ozoko is a Nigerian actress, and other things. And that was exactly what happened. All these narratives is helps us, you know, it opens the eyes, even the eyes of people, even my own supervisor, who is a complete English woman, to see exactly what's going on in the system. So what can we learn from others' malaria experience? Going back to the first slide, in terms of judging the words of stories as meaning-making events, Abraham suggested, their value lies in their capacity to make sense and enrich their awareness and understanding of others. And making sense must here be understood in its most direct meaning. The story, this narrative of these women has opened my own eyes, has even renewed and rejuvenated my own awareness on the things happening. This way we can now keep malaria on agenda. Thank you. Thank you.
OMICS Group, Madam Chairs, all protocol observed. Let me start by saying it's an honor I feel honored this afternoon to be part of the presenters in this special international conference on nursing and health. I would like to say that as Madam Chair has introduced myself, I'm Sayani Adrina Mrondo from University of Venda, Limpopo Province, South Africa. Let me tell you this. Prior joining the academic field, I was practicing in one of the hospitals, Limpopo Province, in maternity unit as a midwife. Hence, I'm a midwife who is so much interested in maternal and child health. And then, right now, as I'm in the academic field, I'm pursuing my PhD study in the stream of midwifery. And as our first presenter from South Africa has alluded the issue of TB, the topic of my research is centered around TB. However, the focus is on women of childbearing age 15 to 44 years who have been diagnosed with TB. The topic of my presentation as indicated, risk factors and complications associated with TB, with maternal TB. The content of the overview as indicated on the slides, I will not go through. Introduction and background of the study. TB is a bedridden disease affecting and killing both male and female, all age groups. Focus of this study is, as I have already indicated, on women of childbearing age 15 to 44. However, individuals 15 to 19 are teenagers which might be pregnant and infected with TB. Statistic has indicated that 2.9 million new cases of TB are among women and 530,000 children. Is the third cause of morbidity and mortality in women of reproductive age. And it was indicated that 410 million and 74 million women and children died respectively in 2012. Majority they are in resource-limited countries and high-burden areas. And therefore, a majority of people infected with TB are in Asia and Africa where TB is endemic. Then several research studies have been carried out in various countries and risk factors were identified such as HIV infection, poverty, delay in screening and poor treatment adherence. And also in Bangladesh, TB complications such as preeclampsia, congenital TB, abortion were reported. It was also found that the overall mortality of 38% was reported from untreated pregnant mothers diagnosed with TB. However, 22% from mothers who were treated with TB. And in South Africa, study which was carried out in KwaZulu-Natal, from 40% women pregnant mothers diagnosed with TB, complications reported TB meningitis to newborn babies and military TB. And Limpopo province is one of the provinces where in people they are living in a poverty state, and hence therefore delay in screening in deep rural areas is due to poverty. Problem statement: HIV in pregnant women is the main risk factor of TB infection due to immunosuppression. Initiation of PMTC program since 2001 showed shortfalls in implementation of PMTCT in district hospitals in Limpopo province, and hence leading to maternal and neonatal mortality and morbidity. Delay in screening, diagnosis, and commencement of anti-TB treatment and untreated TB leads to maternal and neonatal TB complications. Literature search regarding risk factors and complications associated with maternal TB do not reveal much evidence. Particular attention is not given to pregnant mothers diagnosed with TB, as there is not enough evidence or enough reports which is presented nationally and provincially. The purpose of this study is to describe the risk factors and complications associated with maternal TB, objectives to identify maternal and neonatal complications and describe the risk factors and complications. Methodology which was followed quantitative and descriptive design, wherein a checklist was used. Non-probability purposes sample approach was used to select the 10 hospitals and even the 150 maternity medical records. Pre-testing was done using 15 records and did not form part of the study, major study. Reliability and validity were maintained, as well as ethical consideration wherein permission was sought from relevant parties. Data analysis was performed using the statistical package of social sciences version 22, wherein the frequencies and percentage were used. Results of the study, I will not read each. However, it was presented according to the three groups. The first part of it is the demographic factors, of which some of it is issues like marital status and the employment issues. Secondly, the risk factors as which are associated with TB. And from these results, there are the numbers which are highlighted in red, and these numbers indicate the significant factor. So, similar to the risk factors, I will not go to read through, but issues like the late presentations, and as well as the period during which either the sputum smear or chest X-ray was done. And this is the continuation of that risk factors. And then lastly, it was all about the maternal and neonatal complications which had been identified from both mother and the baby. The discussion of the findings, I have taken into consideration only the risk factors which were identified, which are significantly related to TB. High maternal morbidity in South Africa contributed by many factors, but however, HIV is a significant risk factor. And then identify risk factors expose pregnant mothers and neonates to be at high risk of TB as indicated. We find that unemployment is a significant risk factor which affect the quality of life of women of childbearing age, and thus on the other hand, you'll find that these risk factors which have been identified, they are interrelated in the sense that once there is unemployment, as I've already indicated, that Limpopo province is an area where in majority of the people, they are living in a poverty state. It means that majority of the people, they cannot afford to buy food for themselves or either for their families, thus resulting into malnutrition. And malnutrition on the other side lowers the resistance of the maternal health, and thus putting mothers at high risk of TB infection. Therefore, further on, late presentation can be associated with these issues, as once there is unemployment, depending on a situation where the health facility is situated. If it's not within the walking distance, it means that mothers could not be able to walk or maybe to afford to pay for the transport to the health facility, and thus present late at antenatal care, and thus delay in screening and then diagnosis and commencement of anti-TB treatment. Then, 5 minutes left. Thank you. I will be done in 5 minutes. This is just the continuation of that, as I've already indicated that they are interrelated. But however, we do find issues like alcohol and smoking, which are of less significant, but because we are dealing with the mother and the baby, it could not be ignored. And then the complications from the mothers, as indicated, it was found that 53.3% had a variety of complications as indicated. However, the last two bullets, MDR and TB relapse, might be associated with poor treatment compliance or whatsoever. And then thus the postpartum hemorrhage as a complications, and the neonatal complications, prematurity and low birth weight is the ones which are very much common. And then the recommendation establishment of the guidelines related to prevention and complication of TB, and then new research studies to be initiated to various techniques which need to be sought and implemented to improve treatment adherence for pregnant and breastfeeding mothers. In conclusion, untreated late screening diagnosis of maternal TB and late commencement of anti-TB treatment, they are associated with maternal and neonatal complications, and several risk factors identified. Emphasis on integration of bank, TB, HIV, and PMTCT program to achieve and sustain the MDG 4, 5, and 6. Acknowledgement as indicated, and then thank you so much. However, I would like to hear lots of comments as I'm about to reach my destination of a PhD. Thank you.
To Selina. Thank you. I just want to thank this OMICS Group for giving me this opportunity to present this topic or title that I'm gonna present now. As my name has been already indicated, I'm Ms. Rali Paswa from University of Venda, and I'm a PhD candidate. Then my research topic, it has been done at one of the public hospitals at Pembe district in a rural area, as it has been already indicated that we are from a rural area in Limpopo province, South Africa. Then Limpopo province is, in fact, Pembe district is having 8 hospitals, of which the research setting was conducted in a referral hospital. Even though it is a referral hospital, of all these 8 hospitals, it has 1 pediatrician and 3 interns. And then The pediatrician works from the neonatal units and even in pediatrics, of which in pediatrics it admits children from or infants from 1 month up to 13 years. So I'm gonna start now with my presentation. Okay, these are the topics to be discussed, of which I'm not going to read them all. Sorry. The objectives were to describe mothers' challenges related to hospitalization of their children and to propose a recommendation to assist registered nurses to support mothers. Background: hospitalization of a child. Mothers became more stressed when their children are admitted because the outcome is uncertain and procedures are often painful. So you'll remember that when a member of the family, especially a child, is admitted, everybody in the family becomes distressed, more especially a mother. And hence, you know that a mother is always in constant contact with a child, of which when the child is admitted, though other members may be affected, the mother is the one who is mostly affected. And when we said the outcome is uncertain, you know, while we are at the hospital or when you are hospitalized, anything can happen. And then the hospitalization can be successful or not. And then nature and severity of the illness. This brings an intense emotions of anxiety, sadness and anger. Wong and Wilson emphasized about the stresses that parents experience when children are admitted at the hospital. One of the most important sources of stress will be anxiety about the child itself and its condition. Though the severity of illness depends on how one perceives it, because the way I see a sick child or the severity of a child might be the same way as others can see it as being severe. Parents reacting to child's illness and their role. Initially, a mother may react with disbelief, especially if the illness is sudden and serious. Following realization of illness, parents react with anger, guilt, or both. They tend to search for self-blame on why the child became ill, or project anger at others for some wrongdoing. This means that once the child is sick or it's ill, as a mother, you tend to check or to just to look at yourself. What is it that you didn't do that you should have done, so that maybe the child cannot become ill? And culturally, as Africans, you know that once somebody is sick, mostly will say, no, something has been caused that illness, and more especially we will believe that that person maybe has been bewitched. So we always point a finger at somebody. So that's what will always happen when we said the mother will project anger at others for the wrongdoing. Traumatic experience on routine examination. Physical stressors include child's pain and discomfort, like injections and suctioning when necessitated. Sleep deprivation or disturbed sleep due to hospitalization, due to hospital routine like medication at night or vital data, as well as child being fed via nasogastric tube or intubations. All these are very traumatic experience when, more especially with the child, because you remember I said in fact the children that I was looking at was from 1 month to 2 years. So having look at when a child is intubated, being fed via nasogastric tube, obviously it's a traumatic experience. Methodology. Then the research design was explorative, descriptive, qualitative research were used to describe the challenges as they were lived by mothers. Population and sampling. population consisted of all mothers whose children were admitted for not less than 3 days in the pediatric medical ward of one public hospital in Bembe district during October 2012 to December 2012. Non-probability sampling method was used to sample 11 mothers. The inclusive criteria were mothers aged 21 to 35 years, which children were admitted 1 month and 2 years of age. Of course, they must be willing to participate. Data collection was done using an in-depth individual interviews, and interviews were done using Chivenda. That's the language that the participants were easily communicated with and then translated into English. Note-taking and voice recorder were used to capture all the information from participants. Data analysis. The narrative data from interviews were analyzed qualitatively using open-coded method as described by Criswell. Criteria to ensure trustworthiness were used. Results. One theme and 4 sub-themes were imaged. Number 1, report giving versus lack of report giving. Mothers felt that information about the care of their children was not properly given to them. This is one of the quotation. My child was taken to X-ray department and came back. The results were not communicated to me. I'm in darkness. I feel very helpless. Number 2, lack of execution of parental role during child's admission. Mothers had a challenge of not displaying a parental role on basic care. As a mother, I see my child lying there and I need to do something like bathing a baby. Then I feel happy that I'm taking care of my baby, but nurses refuses. You remember that as a mother, when a child is sick, more especially even though you know that even if the child is not sick, but you are always next to a child, but when a child is sick, obviously everybody wants to be next to the child just to give support, and that at least you know that you are doing something to help the child. Misconception versus understanding at hospital procedures rendered. Mothers need to be informed about the hospital routine and procedures. This is also supported by Batupili principles, wherein with the Batupili principles, they need to be consulted, informed, to be treated with courtesy, and so on. The quotation, I was so scared when my child was having wires on the chest with the machines. I did not know what they were for. Personal suffering versus satisfaction related to child's disease prognosis. Mothers revealed that they were not happy to be told that their children were going for admission. I was very frightened. I thought my child will die. Recommendation, establish therapeutic relationship, therapeutic environment, and proper communication. Conclusions, from the above discussion, it has been noted that there is a great need to involve mothers in the care of their children. Both mother and child benefited from responsiveness. Mothers gain confidence, competence, and satisfaction in the maternal role. Thank you. Doribua.
Thank you.
12 o'clock, hearing people, women mostly, with wheelbarrows talking, meaning that these people didn't sleep, they were trying to fetch water. So it got me thinking, when do those people sleep? That is why I decided to do this study. Factors contributing to water scarcity and its health implications at the village that I'm working. Water is an essential resource for life and good health. Lack of water to meet daily needs is a reality today for 1 in 3 people around the world. Nearly 51% of the population in sub-Saharan countries lack access to safe water supply. 41% lack adequate sanitation. Approximately 80 million rural South Africans do not have access to adequate sanitation. Lack of access to clean water, poor sanitation and hygiene are the main risks attributable to diarrheal-related diseases in South Africa. The greatest concern is that people continue to adopt unsafe hygienic practices in South Africa despite an array of diversified efforts that have been mounted towards adequate sanitation. Problem statement. Mhlabeni is located in Limpopo province in South Africa, which is one of the most poorly developed provinces when it comes to water infrastructure. A note, it's because we are coming from Limpopo, that is why we're talking about Limpopo. Everybody who has presented before me is talking about Limpopo as if it's the most poorest. Even other provinces might be experiencing the same problem, but we are from that side, so that is why we're talking about it. Over the past 3 years, there's been water scarcity where there is no piped water. Community members, therefore, fetch water from other sources like ponds, dams, and rivers, which is contaminated. The objectives were to describe factors that contribute to water scarcity, to determine the health implications of water scarcity, research, design, and methodology. It was a qualitative, exploratory, and descriptive study that was used to explore and describe those factors contributing to water scarcity and the health implication thereof. The context of the study was the rural community in Vhembe district of Limpopo province in South Africa. The population of the study included Mhlabeni community members, professional nurses from the local clinic, and community and workers from the Department of Water Affairs. A non-probability purposive sampling was used to ensure that community members who participated on the focus group discussions were the ones who met the sampling criteria. Data collection. Data was collected in 3 folds. Number 1, there was focus group discussions, which was done with the community members. Written interviews, there was a semi-structured interview guide for the nurses, and face-to-face interviews with the Department of Health of Water Affairs workers. Data saturation occurred after 10 focus group discussions, 6 written interviews, and 2 in-depth face-to-face interviews. Data was analyzed using text 8 steps of open coding. Discussion and findings. Natural and man-made factors emerged as the main causes of water scarcity, and they were supported by the following sub-themes. Number 1, poor water infrastructure. Poor service delivery is number 2, insufficient rainfall. And the health implications, physical health effect, and waterborne diseases. Poor water infrastructure, Participants explained that water scarcity was due to damaged water infrastructure where pipes were old and rotten, and some pipes which were supposed to be underground were outside and damaged by the sun and human activities like walking and plowing. They also expressed that there was a shortage of dams, which was also contributing, and there was no reliable source of water. When discussing water infrastructure, one participant said, "The main lines which are coming from Malamulele, which is a nearby town, are very old and rotten because they have not been replaced in a very long time, so water links through. There was only one tank in the village, as mentioned before, which was supposed to be supplying the whole community, sometimes once or 2 days a week, and mostly it was at night. Poor service delivery. Participants indicated that the government was failing to provide water and sanitation to the community of Nhlabenisi. Apparently, before the democratic government in 1994, the community had boreholes which supplied them with water. One participant reported, "The government is failing us because since they came into power, there is never a person who came to attend to our shortage of water issue. And we are suffering because at times we do not sleep." Insufficient rainfall. Lack of rain also contribute to people tampering with the pipelines because they want water for their the cattle, because the dams, ponds, and streams have dried up. Another participant confirmed this by saying, "The main line passing the fields in the bush has been broken by the head boys so that their cattle can drink water from the stream, and the dams do not have water where they can drink due to lack of rain." Health implications of water scarcity. Physical health effects. Aged participants expressed their frustrations when discussing physical health effects, as they were the ones suffering most. They were forced to walk long distances with wheelbarrows and 2 or 3 25-liter containers with water, which was strenuous to their already deteriorating health. Aged participants explained that if they failed to fetch water themselves, they were supposed to pay someone to fetch water for them, which was aiding a strain on their finances, as most of them depended on an old age grant. One participant said, "If I am to get water, I need to hire and pay a boy to fetch me water." I just feel tired. Participants explained that they were not getting enough sleep because whenever water came out, it would be during the night, and they will be awake the whole night, and it's strenuous to their bodies, especially to school children. One of the teenagers was emotional when she said, "We are suffering in this community because of water scarcity. We go for months without running water from the pipes. When it does comes out, it is at night, and we spend the whole night trying to get water. In the morning, we are tired." Waterborne diseases. I think this is the last finding. Diarrhea statistics from the local clinic showed an increase in the incidences of diarrhea, especially in children under the age of 5 years and those living with HIV and AIDS since the beginning of water scarcity. Participants expressed their emotional distress when talking about drinking unclean water, which was making them sick. One participant said, "We are living like animals. Sometimes we are forced to drink water with them in the stagnant waters." Although there were no cases which have been reported in which are directly linked to drinking water with animals, some studies have shown that there are effects like stomach cramps and skin irritation due to that. Conclusion, based on the result, the following recommendations have been made. Water and Sanitation Committee should be established, training of home-based carers on sanitation issues. The clinic should work as an information center. Enko.
Thank you, Riranzu. We can invite question, comment. Seems
My name is Chibase Shonisani Elizabeth. I'm going to present the topic as it stands. I'm from the University of Venda, Limpopo in South Africa, Vembe district. The study has been conducted in Thulamela municipality. My topic stands as knowledge regarding solid household waste management in Chisauro community, South Africa. Structure of the paper. The paper will cover the following aspects as you see it. Introduction and background of the study, statement of the problem, purpose, research design and methods, results and findings and recommendations. Introduction and background. Solid waste management is the second most important problem after water quality in developing countries all over the world. It is becoming more and more critical because of rapid population growth, urbanization, and industrialization process. All these threaten the health and well-being of the residents and increase the spread of diseases. It affects both urban and rural areas. The problem of waste management is rapid and acute in developing countries because of economic growth and urbanization. When we talk about developing countries, we mean countries like South Africa is one of them, Zimbabwe is one of them, mostly the African countries. Even here in the European countries, we've got countries like India, Asia, those are the developing countries. So South Africa is facing a major challenge as far as waste management is concerned. It has an increasing practice of littering, dumping, and burning of solid household waste. Limpopo is one of the poorest provinces in South Africa. Maybe today you are going to be very much tired of hearing poorest of them, poorest. There are a lot of immigrants coming from other countries such as Asia and other African countries. There is congestion which leads to increased waste generation. Chisauro is one of the villages that is overpopulated due to new building sites and Shandima industrial areas that have been developed. Problem statement. Disposal of household waste is a major problem at Chisauro village. When walking around the street, the researcher observed piles of household solid waste thrown all over the area. Every open space is taken as a dumping area where garbage from households is thrown, including riverbanks and in the bushes. Piles of rubbish are left to rot on the streets and presenting a health risk to children who play in the area, including the community as a whole. Purpose of the study: to assess knowledge and practices of Chisauru community members regarding solid household waste management. Research methodology: a quantitative descriptive approach was adopted in order to assess the knowledge and practices of Chisauru community members regarding solid household waste management. Study setting: the study was conducted at Chisauru village under Tulamela municipality at Vembe district. Vembe district is located in the most rural northern part of the Limpopo province in South Africa. It is characterized by poverty and backlog in the development. It shares its borders with 3 SADC countries like Botswana, Zimbabwe, and Mozambique. Study population: the target population was all household heads of Chisauru section within Chisauru village. Chisauru village is composed of 2,090 households with 5,535 residents. Sampling method: systemic sampling was used to select households to participate in the study from each section of Chisauru register from the office of the local council, meaning that the local council is found at the headman, Mr. Makumbai. The number of households participating in each section was drawn based on the proportion of the population in order to achieve a degree of representativeness. Sampling method: one person who was above 18 years of age had represented each household in this study. In a child-headed family, the eldest child represented the family. We are still having a lot of child-headed family in our area, especially those who have been orphaned due to this HIV, AIDS, and TB pandemic. So we are still having families who are headed by small children, as young as 16 years, as young as 14 years of age. The total household number of residents was divided by the sample size to find K value. Every 6th household was summoned to Chisauru Primary School, where questionnaires were administered. So those are the results in the graph, as you see it on the board. The dark blue represent the percentage of participants, and then the light blue, middle blue represent those that prefer burning as a method of waste disposal, and then the light one is the person shows those aware that their waste can be they can become manure. And then we've got males and females. Discussions and findings. The graph shows the number of participants surveyed about waste disposal, of which the group were divided into 2. There were males and females. More females participated on the study as compared to males, because most of the males, they used to say that women's place is in the kitchen. So women are supposed to answer the question, are supposed to be surveyed, because they are always in the kitchen, they are always handling these domestic matters. More women, that is 83.8%, knew about the side effects of burning of waste as a method of waste disposal, and that it causes respiratory problems. Males did not know about the side effects of burning waste materials. Hence, they still preferred it as the only way of disposing waste. A higher percentage of males are aware that biodegradable waste can be used as manure in home gardens. Isn't it that males usually, they are the one who are cutting grasses, they are the one who are collecting these odd leaves, and then they know that this type of leaves, they become a very good manure. They are fertilizers. Whereas only 84.7% of females knew that waste can be reused as manure. And then 66.4% of both participants indicated that They have not recycled their household waste in the last 6 months. Lower percentage of males as compared to females were not aware that solid waste can cause soil pollution. Recommendations. The study recommended that awareness campaign should be done through the media and traditional imbizo. When we say about traditional imbizo, we mean calling all the residents to come at the local chief's crawl so that health education can be given to the community. It can be given by the health workers, it can be given by the health workers who mean health inspectors, nurses, and the caregivers, and those who have got this, what do we call this? The home-based carer. Yeah, they are usually used to give health education to the communities, because once you give health education to one member, he or she can educate the whole community. And then, therefore, the findings from this study will help to influence Bembe municipality to develop new policies on rural villages concerning solid waste management, because in some of the areas in Chisau, you may find that out of 6 sections, 1 section is the one that is being taken care of by the municipality. So we've got these discrepancies. Limitation of the study. The research was conducted in Chisau village only and did not represent Bembe district. However, the results were vital in establishing a basis for comparing the level of knowledge and practices on solid household waste management between villages. Thank you.
Day. My job is very much simple, as this study is not belonging to me. I'm just coming to read on behalf of, I'm calling her as Rachel. So I'll be reading as I've been required to come and do it. So the topic of this study is the teenagers' perception of reproductive and sexual health services. A case study of selected village within the Greater Giyani municipality in South Africa, again is in Limpopo. The 5 core components of the sexual and reproductive health care are improvement of antenatal, perinatal, postpartum and newborn care, provision of high quality services of family planning, including infertility services, elimination of unsafe abortion, prevention and treatment of sexual transmitted infection, which we call it STI, including human immunodeficiency virus, HIV, reproductive tract infection, cervical cancer, and other gynecological morbidities, and promotion of health sexual. In 1994, delegate from the government of 1979 countries and more than 1,200 non-government organizations met in Cairo at the International Conference of Population and Development and agree on a 20-year program of action to improve the sexual and the reproductive health, foster reproductive rights, and stabilize in the world population. In 180 countries, pledged to support the provision of comprehensive sexual reproductive health services through integrated system rather than through separate vertical program. So the methodology, as it is projected there, is a qualitative, explorative approach, descriptive approach, and then the conceptualized approach. The population, all teenagers, the age 10 to 19 years is a non-probability, purposive sampling approach. And then the sampling, it was in district, village, the school, the sampling of participation, teenagers in Mopani district living in Hlaneki and Ngwamankena village were the participants that they were selected because of high teenage pregnancy that was reported in 2011. And they were interviewed until data saturation was reached. The inclusion criteria was teenagers with both gender, age between 10 to 19 years, to the same village, and consent form was obtained to the participants who are less than 16 years of age. The consent form was obtained from the parent. The data collection, it was through the focus group using the unstructured interview. The field note, observational notes were taken, audio tape were helped in recording during the participation session, and then the researcher collected data with the assistance of language expert and translate where from English to Xitsonga. The reason it was the people who are living at Ngwamankena and Hlaneki, they are mostly they are speaking Xitsonga. And then the test, there is something wrong there. There's no S. The test 8 steps of open code were used to analyze the quantitative data in the study. And theme and subset were imaged. So I'll just project the table and go straight to the themes and the substance. And then the trustworthiness is what is reflected there, the credibility, the transferability, dependency, and conformability. So the permission to conduct the study was obtained from the following authority: UNIVEN, which is University of Venda, Department of Advanced Nursing Science Committee, UNIVEN School of Health Science Committee, Higher Degree Committee, and Ethical Committee of the university, and also the chief of the villages, the 2 villages that I've mentioned. And those are the main themes and the sub-themes. So I'll go straight to the discussion. So the main themes is factor leading to teenage pregnancy. As in the beginning, it was indicated that the 2 villages were selected because there was a study showing that there was a high pregnancy during the year 2011. The study found that in both villages, there was a poor utilization of sexual reproductive health services by teenagers, and it was due to the negative perception towards this program. Most of the teenagers mentioned that they will only visit the clinic when they are sick. They're not regularly visiting the clinic to go to and access this program. The participants expressed the frustration, especially when they try to go to clinic for their services, and most of them were not happy with the nurse's attitude. They rather use the herbal medication rather than going to access these services. They indicated like some, they are not clean inside and they become infected after abortion. In this statement is when the teenagers fell pregnant, instead of going and do the safe abortion, they rather go and do the back door abortion or unsafe abortion. They will only go to the clinic when they experience the complications. personal factor leading to teenage pregnancy. The negative, most teenagers insist that lack of parental supervision, peer pressure, ignorance among teenagers, and then need of child grant, and is the most reason of engaging in unsafe practices. And then the negative attitude towards HIV were the main personal factor that hinders them from accessing the using the services. The teenagers also mentioned that some parents leave them at home alone, and then they give the freedom that they can do anything, they can sleep around because there's a poor supervision there. And then in terms of the peer pressure, you'll bear with me that in peer pressure, there is a lot of competition and conformity. If you are not having the Cavella, you'll do anything that will assist you to go and get that thing. So they date the boyfriend in order to get such thing, in order to conform in the group. And then most teenagers become pregnant because they don't listen to their parents. They don't believe what their parents are saying. And teenagers articulate is just that teenagers, they want money for child grant. As I mentioned, that the child grant is one of the factors that contributing to the teenage pregnancy. They fell pregnant because they know after getting the baby, they will get the child support grant. So they rather become pregnant than preventing. Sexual intercourse preference. Teenagers prefer having sex without condom. And then one of the participants says, I don't know, but condoms, I see them. But instead of using them to prevent for HIV, they use them to hold for the socks. I don't know in other countries. They hold the socks with the condom so that the socks cannot fall down. And then most of the teenagers experience that HIV is not a threat to them. They don't perceive HIV as a communicable disease, which is a chronic illness. They just perceive HIV like a flu. It's like a flu, and they take it for granted, like a cough. They tell themselves that these days everyone has HIV. So to them, it doesn't bother them. Institutional factors leading to teenage pregnancy, negative attitude of the health professionals is where they mention many people, more especially girls, when they go to the clinics, instead, before they access the service, they were forced to do the HIV test, so they don't go to the clinics because they're afraid to do the HIV test. And then the long-standing hour blamed by the teenagers. Yes, our health system, the primary health system, the queues are still long. And then the teenagers, they say, because they don't tell their parents when they go to the clinic, they rather lie to say, I'm going to the spaza. So because of that long queue, they tend not to go to the clinic. And then lack of privacy, they are saying the healthcare providers gossip a lot. The cultural taboos. Taboos to teenagers, non-utilization, every few participation indicate that parents were not talking to them about their sexual matters. The indigenous abortion, instead of going to the hospital or the clinics for the safe abortion, they rather used. They mentioned something like boiling Coca-Cola and drinking spirit for the abortion. And then in conclusion, non-utilization of sexual reproductive health amongst teenagers is the main cause of the most teenagers not being able to meet the ideal in life, as most of them end up in teenage pregnancy. Parents also have a major role to play, accepting that their children are no longer just children. Some started sexual activities at a very young age, hence they needed to be open and talk about them and their sexual. and most teenagers feel shy and scared to go to the clinic. Hence, there is a need to ensure that health caregivers change their attitude towards the teenage who comes for the services.
Thank you, Ms. Loana. It's scary. We have a lot to do as health professionals to our teenagers. Any question, comment? Thank you very much. Will be coming?
Yeah. And, we're going to announce the Best Poster Awards. And the first one goes to Sinead Johnson from Johns Hopkins University. And that is, her poster was entitled Managing the New Normal, Assessment and Management Practice for Gynecological Cancer Survivors. Congratulations. Is this you? Please come up and accept your award.
Okay.
Very good.
The second, it's not second best, it's the second one. Best Poster Award awarded to my girl Loane, University of Venda, South Africa, for presenting the poster entitled Knowledge of Clinical Nurse Practitioners regarding notification of notifiable infectious diseases in Greater Tzaneen Municipality, Mopani District, Limpopo Province.
Very good.
Congratulations. Thank you. So we have our important presenter of the last but not least. We have Nesani Kenneth. He will be reading a paper on male partners' view .
Thank you very much. A lot has been said about Limpopo and South Africa, so I won't dwell much on that. My name is Nesani Kenneth. My study was male partners' views of involvement in maternal health care services at Makarobi local areas of Vembe district in Limpopo province of South Africa. Introduction. Male partners have a strong influence on pregnant partners' health and their access to health care. Their involvement is critical in the delivery and uptake of maternal health care services and to improve the maternal and child health outcomes. The thing that motivated me to research about male partners' involvement in maternal health care is because when I was working at the clinic as a professional nurse, female partners were coming alone for antenatal clinics. I was wondering where are the partners? Does they don't care or what? But we will see when we go on. Aim of the study. The study sought to determine the male partners' views on their involvement in maternal health care services. Setting, it was conducted at Makadobi local area clinics, which was Madumbija, Kutama, and Flefontaine clinics. Method. The study was qualitative design, which is exploratory, descriptive, and contextual in nature. Population consisted of 10 male partners, whose partners were pregnant within the last 2 years. Non-probability purposive sampling procedure was used. Data was collected through in-depth interviews, individual interviews, using the voice recorder and the interview schedule guide. Test open coding method was used to analyze data. Objectives of the study. The objectives of the study was to explore the views of male partners on their involvement in maternal health care services and to determine the views of male partners on maternal health care. The results. The findings revealed one major theme, which is maternal health issue are viewed as women matter, and 3 sub-themes, which are culture and participation in childbirth, maternal partners, employment status, and unwilling to participate in maternal health care services. Recommendation. The recommendations of the study was to facilitate promotion of involving male partners in maternal health care. To policymakers and for further research we proposed. In conclusion, the results of the study revealed various views of male partners on the involvement in maternal health care services and some of the factors that affected such participation at the selected clinics of Bembe districts. Men's commitment during pregnancy and childbirth not only plays a vital role in the safety of their female partners, but also ensure access to care and provision of emotional and financial support towards RS in general. Thank you.
Thank you, Kenneth, for short and sweet presentation.
Thank you.
Any comment, question?
Oh,
I think we are saturated. Oh, there's a question.
Yeah.
Okay, good afternoon. So I find the study very interesting because it highlights the role of men in taking good care of their wives. But I'm just wondering, because it may sound on a different cultural context, why is it that you use male partners? Because perhaps we have this kind of notion that we usually use spouse or other term, but I'm just wondering why male partners, or that's the term used in your study.
Okay, thank you.
Thank you.
Okay, I used male partners because I wanted to find out from them straight what is that where are the barriers of their involvement in maternal health care services. Just because if I can ask the women, she don't know. Just because in Africa, women respect their husband too much. She can't ask, why don't you accompany me to the hospital? Why don't you accompany me to the clinic? You see, it's not easy. Many of them were talking about cultural barriers in this, which was the one which was hindering them to involve in maternal health care services. All right.
It's just a general term used also here in the United States. You don't have to be married, you don't have to be boyfriend, or you don't have to have a relationship, but it's just a partner that is maybe an intimate partner. That's what we use the term. Yeah, it's any partner that really could be involved in the care and in the birthing or the pregnancy of the woman. Yeah, it doesn't have to be the father of the child. Some of them would be, you know, just a relationship that happened. Thank you.
Thank you very much. It's not a question. It's just a suggestion. As if, what about if maybe you should have indicated from your sub-themes that came out, maybe one quote from each, so that we can be able to hear or to see how they have responded to your questions.
Okay.
Thank you.
Don't worry, I will forward the study to you.
Next study.
This one, I will forward it. I will forward it to her. Yeah.
Well, I want to say that I feel like that Limpopo has a great set of nurses that is going to change that area. Mm-hmm. And I appreciate all that you're all doing.
Thank you.
Thank you, Lisa. We did the posters already. Thank you very much. We have announced the winners. We are descending our flight. Thank you very much for